Let's discuss anxiety. My knowledge on tips. Subscribe for more learning outcomes. After listening to this course, you should be able to understand anxiety from biopsychosocial perspectives. Discuss contemporary issues in mental health science related to anxiety. Recognize different lines of evidence and appreciate the uncertainty, ambiguity, and limits of current knowledge in the study of mental health science. Common misconceptions about mental ill health. The following section is based on resources provided by the World Health Organization, Mind, Rethink Mental Illness, SANE, NAMI, the U.S. Department of Health and Human Services, the Australian Government Department of Health and the Canadian Mental Health Association, all of whom are gratefully acknowledged. Consider the statements that follow, and click to reveal the truth behind them. Mental illness is not a real illness. False. Mental ill health is not simply the regular ups and downs of life. It creates distress which does not simply go away by itself, but can be managed through effective interventions. While some people who experience mental illness may act in ways that are unexpected or appear different to others, these cannot be generalized. The behaviors or experiences associated with mental illness are not by choice. Equally, like anyone else, people with a history of mental ill health may make poor choices or behave unexpectedly for reasons that are unrelated to symptoms of their illness. No one would choose to have a mental illness. It can sometimes be challenging to relate to the symptoms and personal experiences of people living with a mental health condition, if one has not experienced these for themselves, but this does not mean that their condition is somehow not real. People with mental illness are typically violent, unpredictable, and dangerous. False. Having a mental health condition does not make a person more likely to be violent or dangerous. The causes of violence are complicated, and mental illness is not a predictor of violence. Few violent acts can be attributed to individuals living with a serious mental illness. The abuse of illicit drugs and alcohol may perpetuate violent crimes. People who experience mental illness are often amongst those who are excluded from communities, vulnerable, and more likely to be victims of violent crime or of self-harm than of violence towards others. The false perception, popularized in the media, that people with mental illness are typically violent, unpredictable, and dangerous, is amongst the most damaging of stereotypes. People who experience mental illness are unable to work. False. Depending on the severity of their condition, living with mental illness does not necessarily mean that a person is incapable of seeking or maintaining employment. They may require additional support or suitable working arrangements provided by employers. Those with more serious conditions may face some barriers. Mental illness is a result of bad parenting. False. Mental illnesses are complicated conditions that arise from a combination of genetics, biological, social, environmental, life experiences, and other influences, and not simply a consequence of parenting. 1 in 5 children aged between 13 and 18 will have a mental illness. Around half of all lifetime cases of mental illness begin before the age of 14. Parents and family members have a major role in support and recovery. There is no such thing as mental illness in adolescence, it's just puberty and signs of teenage awkwardness. False. Errant, challenging or withdrawn behavior, and sudden changes in mood at school or at home during adolescence are often seen as a sign that a young person is simply acting out their frustration at struggling academically or socially. Adolescence is a period of significant physical and emotional change, brain development in particular, so it is important to understand the underlying reasons for changes in mood and behavior. Mental illness affects people of all ages, including adolescents. Specific criteria for a clinical diagnosis will need to be met, and it is important to distinguish mental ill health from transitional teenage behavior, moving towards adulthood. Up to half of all mental health conditions show first signs before the age of 14. However, it is estimated that up to 20% of those diagnosed do not receive the treatment and support they need. There is no recovery from mental illness once you have a diagnosis, it's all downhill from there. False. Mental illness is not always a chronic, lifelong condition. People who experience mental illness can recover and lead fulfilling lives, learning to manage symptoms with support and appropriate treatments. Many people living with mental health conditions are able to live, work, learn and participate fully as active and productive members of communities. When treated appropriately and early, some people can recover with no further episodes of ill health. For others, ill health may recur throughout their life, and will require longer-term management to help people live full and fulfilling lives. Counseling can help to avoid reliance on harmful coping strategies like drinking, as well as to help come to terms with life experiences. Often a combination of pharmacological, medication, and psychological, talking, therapies provides the best outcomes. Individuals have different treatment needs. Talking with mental health professionals will help to determine the best treatment plan towards recovery from mental ill health. Depression is inevitable as one gets older. It's a sign of old age. False. Depression is not inevitable in old age. However, older adults do have a greater risk of depression associated with losing a partner later on in life or as an early sign of other progressive illness, including neurodegenerative diseases and dementia. Mental illness is the sign of a weak character. People with depression are just lazy. False. Ill health, whatever the cause, is not a character flaw or personal weakness. People with mental ill health are not lazy, weak, or able to snap out of it. The stereotype of a clinically depressed person as being lazy, or simply lacking motivation shows a lack of understanding of the condition. Multiple factors contribute towards mental illness, including life experiences, trauma, family history, physical illness, or biological factors. It is not entirely clear why some people are more resilient to developing mental illness than others after, for example, witnessing a traumatic event, being a victim of a crime, or longer-term exposure to traumatic experiences, such as military conflict, natural disasters, or abuse. Not everyone exposed to a traumatic event will experience post-traumatic stress disorder, PTSD, for example, but this is not related to some notional concept of being strong or weak-minded. Prevention doesn't work. It's impossible to prevent mental illnesses. False. If risk factors are known, e.g. exposure to a specific trauma or known biological or environmental stimuli which can trigger mental health problems, then strategies aimed at preventing these would affect mental, emotional, and behavioral outcomes in children and adolescents, as well as adults. People with mental illness should be isolated from the community and kept in institutions. False. Many people with a mental illness recover quickly and do not necessarily need hospital care. Others have short admissions for treatment. Improvements in healthcare provision mean that most people can live within the community while receiving the continued care and support they need, without being confined to psychiatric institutions, as was more common in the past. Some people, however, will require long-term specialist hospital care, and sometimes against their will, if they are deemed to be particularly vulnerable or likely to cause harm to themselves or to others. For example, people with depression are just sad, they need cheering up. False. There is a misconception that people who are clinically depressed can simply will away their mood, shake it off, pull themselves together and cheer up. Depression has a biological basis that affects physiological functioning. It's not as simple as a psychological pick-me-up. Treatments such as cognitive therapy combined with medication can help address the symptoms of depression. Different ways of viewing mental distress. Notwithstanding the misconceptions discussed in Section 1, there are different, clinically accepted ways of viewing mental distress. Physical explanations of mental illness are centered around the notions of changes in the underlying physiological systems within the body, the neurobiology of the brain, genetic predisposition, and interaction with the environment. Psychological explanations focus on behavioral and cognitive constructs, often reflecting social and environmental influences. Social explanations are based on an understanding of difference and discrimination, societal factors that separate people and may oppress them. Now let's discuss the two models of explanation, the biomedical model and the biopsychosocial model, in more detail. The biomedical model. The view that has predominated in medical practice over the last century, and still holds to varying degrees around the world, is one where mental illness is seen as a disorder, a pathology or a disease to be diagnosed, treated and ultimately cured. The focus on disease rather than the person as a whole requires definitions of what is considered normal versus pathological and judgments that are concerned with establishing boundaries, leading to a diagnosis. This biomedical model suggests that disease is by definition associated with identifiable disturbances in the body and can be defined in terms of such disturbance. A cure would consist of correcting the disturbance. So, by this criterion, cancer is clearly a disease, as is coronary artery disease, an artery blocked by buildup of cholesterol and other material causing narrowing of the blood vessels. If a form of mental distress has as its cause a measurable basis in a bodily disturbance, then, applying this criterion, it would be considered a disease for which medicine is the obvious treatment. But how can psychological distress fit within the criteria for disease? This has led to a dichotomy in views amongst mental health professionals on what is or is not considered a disease, based upon biological criteria. Others have suggested that the biomedical model can be universally applied to all forms of distress, whether or not there is an identifiable disorder in the body. Hence, no matter what the distress, presumably a biological intervention in the form of medication, pharmacological treatment, would be appropriate. There are limitations to the biomedical model. Usually, an individual in mental distress will present because of some form of pain, discomfort, or distress which is subjectively experienced. Even if a disturbance within the body can be identified, it may not necessarily be the primary reason for which an individual presents for treatment. Engel, 1977. There are also cultural and social dimensions in how such expressions of distress are made and help is sought. A biological explanation alone, therefore, cannot provide the full picture. The biopsychosocial model rejects the neat dichotomies of the biomedical model. The biopsychosocial model. The biopsychosocial model introduced by George Engel in the late 1970s adopts the perspective that a full understanding of mental distress, as well as of mental health and well-being, involves a study of the biology of the body, usually with an emphasis upon the brain, an individual's psychology and their social circumstances. According to this model, disease defined simply in terms of biology, is not a useful way of approaching distress and well-being. A central assumption behind the biopsychosocial model is that, not only do the three factors biological, psychological, and social play a role in any form of psychological distress or well-being, but also that there is interdependence between them. For example, changing an individual's social circumstances can change his or her psychology. Changing an individual's psychology can change their social interactions. Changing a person's psychological state will also change the activity of their brain. A change in the underlying brain activity, for example as a consequence of traumatic brain injury or a physical illness, can change the individual's psychological state and their behavior. In these terms, biology is not an absolute defining criterion of when there is mental distress, but neither is it irrelevant. A biological explanation can contribute to mental distress, but should be considered as one contributory factor amongst three. In health or ill health, biological and psychological contributions will always be present. In one sense, in the very rare cases of, for example, a person living alone on a desert island or a hermit in a cave, there will not be a social factor present. However, such a person will still have a history of earlier social interactions which will have left their mark. So, according to a biopsychosocial model, the relevant question is not which factor, bio, psycho or social, is the most important since they are interdependent. At whichever level a change arises, there will be consequences for the other two. For example, a social change, such as finding a new job, a marriage, divorce, or a bereavement, the loss of a loved one, will have obvious implications for a person's psychology, which simultaneously affects the brain. But a change does not necessarily occur in only one of the three factors at any one time. The concepts of holism and reductionism. A biopsychosocial perspective is a form of holism. This approach examines the three interdependent factors, biological, psychological, and social, in devising explanations and possible interventions in mental health. From this perspective, all three factors are equally valid as objects of study. The term reductionism refers to a process of trying to explain events by focusing on only one component of a complex whole. So, in explaining behavior, a study of biology to the exclusion of psychology and social context would be said to be reductionist. Similarly, to explain psychology simply in terms of social context, whilst ignoring biology, would also exemplify reductionism in this sense. Another shade of meaning of reductionism is in seeking explanations at a smaller scale. An example of this would be searching for an explanation of mental, behavioral, and social events in terms of activity of regions of the brain. To take such reductionism still further, activity of the different areas of the brain would then be explained in terms of the chemicals that make up the brain, neurochemicals, and the performance of these neurochemicals might then be explained in terms of their component parts. The biomedical model exemplifies reductionism in both senses. An exclusive focus upon social context to the exclusion of biology and psychology illustrates reductionism in only the first sense of the term. Limitations and clinical relevance of the biopsychosocial model. The biopsychosocial model is therefore arguably more integrative, non-reductionist clinical and theoretical model that honors the importance of all relevant domains of knowledge, not just the biological. Benning, 2015. While it is considered as a more inclusive model relevant to medicine and psychiatry, and an improvement on the more reductionist biomedical model, Deacon, 2013, it is still not entirely free of criticism. Those levied against the model include, I. The dominance or underrepresentation of each of the three domains, bio, psycho or social, when applied to research and clinical practice, and 2. The insensitivity of the model to individual subjective experiences and personal meaning, particularly within cross-cultural settings. There are still those who perceive psychiatry as biased towards biomedical paradigms, at the expense of the psychological and social domains, and conversely that psychologically and socially oriented thinking and approaches are equally biased, at the expense of the biological domain, making the model difficult to implement, i.e. to translate or replicate in research, or to apply within clinical practice in current healthcare systems and services. Application of the model is also reliant on the practitioners, i.e. clinicians or researchers, own understanding and working knowledge of the three domains, affecting treatment selection, clinical judgment and decision-making, Alvarez, Pagani, and Musi, 2012. And consequently, the model does not always translate as combined or personalized treatment for the individual, although the combination of psychotherapy with pharmacotherapy is gaining wider recognition globally, and practitioners have found the model difficult to incorporate into treatment plans, Alvarez, Pagani, and Musi, 2012. In terms of an integrative model that could improve on Engel's biopsychosocial model, key issues that remain to be tackled, Kendler, 2010, cited in Benning, 2015, p. 349, are how to integrate the diverse etiological factors that contribute to psychiatric illness and how to conceptualize rigorously multidimensional approaches to treatment. Nevertheless, the ability to draw together these three aspects bio, psycho and social to critically evaluate evidence and explanations and in this manner gain a broader, more holistic picture, remains key to understanding mental health science. Understanding mental illness also requires viewing mental distress from the standpoint of those who have experienced it, as well as an appreciation of societal and cultural views, and how mental illness and mental health research are portrayed in the media. 2. Mental health research in the news. Why is it necessary to present scientific and clinical research results in a clear, accurate, and concise way? How are research findings and new knowledge disseminated? Why is it important to think about the target audience? The answers to these questions may well be obvious to you, but are worth exploring further at this point. Contemporary research is by necessity the work of specialists, and communicating research findings is a key priority that allows investigators to remain at the forefront of their respective field. Researchers typically disseminate their new findings by means of oral or poster presentations at conferences and symposia, and follow these up by publishing the results in peer-reviewed journals as a formal means of communication to peers, specialists and practitioners, working within the field. Communication in this sense is not restricted solely to peers, other specialists or a professional audience within a chosen field. Researchers are also frequently called upon to communicate their findings to other specialists as well as non-specialist and lay audiences, including the general public. Such forms of knowledge transfer can involve use of different media, written reports, government or policy documents, blogs, podcasts, video clips, news articles, and radio or televised broadcasts aimed at specific audiences, policy makers, funding councils, professional bodies, charitable organizations, the mass media and the general public, amongst others. Complex issues that are tackled by research in today's global society increasingly require a multidisciplinary approach and involve cross-disciplinary communication, with close working relationships and collaboration between researchers from different backgrounds and fields of study. Motives for engaging with research targeting issues that are widely perceived as important may vary and need not be necessarily altruistic. Dissemination of knowledge, however, enables scientific and clinical progress to be made, allows new hypotheses to be formulated and tested, increases public awareness of developments in science and medicine, and of their benefits to society, and raises awareness of mental illness further. These activities depend on the appropriate selection of trustworthy and reliable information, and timely and effective communication. The Science Media Centre, Mental Health, Research and the Media. The UK's Science Media Centre, SMC, an independent press office that emerged from the House of Lords Science and Technology Select Committee in 2002 with the aim of increasing public awareness and trust in science, serves a key role working with journalists and experts within the scientific community. The SMC strives to provide, for the benefit of the public and policymakers, accurate and evidence-based information about science and engineering through the media, particularly on controversial and headline news stories when most confusion and misinformation occurs. Originally based in the Royal Institution of Great Britain, the SMC is now housed in the Wellcome Collection. It operates on the core belief that scientists can have a huge impact on the way the media cover scientific issues, by engaging more quickly and more effectively with the stories that are influencing public debate and attitudes to science. This function has been demonstrated countless times over the years across the broad spectrum of science in the news. With the increase in reporting of mental health research in the media, and the appointment of a new head of mental health at the time, the SMC drafted a consultation report, see Box 1, and put forward a set of recommendations in 2010, see Bithell, 2010 and 2013, issues that are still largely relevant today. Coverage of mental health and research in the media. You may have noticed that some broadcasters and newspapers tend to go into greater depth in their reports, provide more accurate, balanced or measured coverage. They may attempt to present an analysis of findings or contrasting points of view, perhaps discussing the implications or limitations of the research in some way to ensure responsible reporting. Occasionally, however, headlines in the press can be more sensationalist. It is important to recognize that the way information is presented in the media varies according to the perspective of the groups and individuals concerned, and these can come into conflict with one another. Some groups may appear to play down a particular concern, while others seek to magnify it, depending on their own interests. What constitutes news may have clear political and cultural sensitivity as well as significance, and sometimes certain aspects can be given disproportionate attention. An example of this, the first item noted in box 1, is the focus in the media on violent crime or incidents perpetuated by or involving individuals experiencing mental health problems. This is arguably one of the most significant contributions to the fear factor and stigma surrounding mental illness within the community. Negative reporting of mental health problems, particularly stories that include elements of stereotypes, see section 1.1 for some common misconceptions, are very powerful. They fuel deep-rooted cultural fears, social fears and anxieties, of mental illness and an unfounded notion that institutions, asylums of earlier centuries, protect society as much as, if not more than, the people who are detained therein. This is clearly a distorted image, one that gives a disproportionate amount of attention to the risk of violence by people experiencing mental distress compared with other risks affecting them. The priority given to the risk of violence is not only highly stigmatizing, but may mean that other types of risk, such as the risk of self-harm, are not addressed. 3 other key issues that were raised in the SMC consultation report, Bithell, 2010, and have a direct bearing on this course, are worth emphasizing here. The first concerns the complexity of this area, the diversity of opinion, and the fact that there are few simple messages, making it difficult to communicate mental health research and broader issues related to mental health to the media. The second, according to the report, is that psychiatry and clinical psychology differ in their approaches to and views of mental ill health, such that many psychiatrists felt that a psychological or social approach, rather than a medical approach, tended to be given undue publicity, whereas psychologists often felt that a medical approach was the dominant view given in the media. Bithell, 2010. The third is that news stories often focus on controversial areas. Experts quoted may not necessarily be the best qualified to comment, and it can be difficult to respond in a timely way to breaking news stories with little warning and tight deadlines. The importance of establishing the provenance, objectivity, and timeliness of information. When it comes to accurate and timely reporting of research, responsibility not only lies with the media who select newsworthy and often controversial pieces, but also with the researchers who are disseminating the knowledge, institutions that were involved, members of the scientific and medical communities who provided peer evaluations, assessment, and comments, any professional bodies or organizations affiliated with the work, and journal editorial boards who will have ensured the validity and credibility of the work as part of a peer review process. The scientific and ethical rigor of the work should have stood up to scrutiny by peers deemed to have sufficient expertise in the area. A failure at key points in this process can have significant consequences, and could ultimately erode public trust and confidence. All the more reason, therefore, at this advanced level of study, for us to go behind the headlines and to begin to explore some of the more contemporary and controversial findings within the field, to evaluate claims and assumptions, recognize different lines of evidence and appreciate the uncertainty, ambiguity, and limits of current knowledge in the study of mental health science. We will be looking at specific examples in later sections. Reflect on your learning so far on this course. What were the key issues that stood out for you? How many of the key issues were you already familiar with? Can you offer further or alternative perspectives, drawing on your own personal or professional experience? The next section will introduce you to issues related to diagnosis, as we begin to explore anxiety. Exploring Anxiety Part 1. The next course should provide a useful starting point to some of the issues that we will discuss over the next 3 sessions. Specifically, the relationship between stressful life events and emotional disorders, the main features of the physiological response to stress, and the role of genetic and environmental factors, which we will briefly review here. It is often the case that those developing anxiety or depression have experienced significant stress during childhood or adolescence as well as in their adult life, and recurring episodes are triggered by stressful life events, e.g. the loss of a loved one, unemployment, divorce, poverty and discrimination. Some personal traits considered to be anxiety-prone can exacerbate the experience and increase the likelihood of developing an anxiety disorder. One of the most potent factors predicting anxiety in later life is early traumatic experiences, including physical abuse as well as emotional neglect or mistreatment. Childhood abuse is a strong predictor for post-traumatic stress disorder and depression in later adult life. There are cognitive styles, ways of thinking, that may predispose an individual to stress and to the development of anxiety or depression. People use different coping strategies to manage stressful situations. An important element is the perception of control over the situation. A person can feel frustrated and anxious if they feel they have no control over a situation or do not achieve the outcome they anticipate. This form of helplessness or hopelessness resembles that of subordinate or defeated status in social mammals, where a hierarchical social structure prevails. Challenging or reframing the appraisal of a situation is an important strategy used by psychotherapists to help people with emotional disorders. Personality traits and temperament, so-called trait anxiety, are also known to be associated with mood and anxiety disorders. Neuroticism predisposes to anxiety, whereas an easygoing and optimistic temperament may help a person cope more effectively with stressors. There is evidence to suggest that genetic inheritance can contribute to temperament. There is a tendency for emotional disorders to run in families, and anxiety can also frequently coexist with other psychiatric conditions, including obsessive-compulsive disorder. The prevailing view is that a combination of predisposing genetic factors can make it more likely that a person will be vulnerable to environmental factors such as stressful events and to developing emotional disorders including anxiety and depression. Alternatively, the transmission of emotional disorders is also thought to pass from parent to child in some instances as a form of learned behavior in which a child models or mimics the behavior of the parent. It has been argued that we now live in a society where people in general are experiencing heightened levels of anxiety, primarily in response to rapid technological and social change. Advances in both technology and communication, the internet, mobile technologies, and social media have given us more immediacy in our daily interactions with others and greater awareness of local, national and global events. Social pressures can dictate how we respond, putting us on the spot. We have access to live information, moment by moment as events occur, and are constantly bombarded by news stories in the media that are filled with warnings, dire predictions, and uncertainties about the future. It can be difficult to switch off. As a society, we are more and more concerned with our safety and with risk, even though most of us are safer than ever, statistically speaking. The consequences of catastrophic events such as outbreaks of disease, nuclear accidents, war, and conflict, and outcomes of political upheaval and instability throughout the world are difficult to predict. So much so, that in industrialized, and typically Western, societies, risk and danger have become synonymous and strongly associated with the possibility of negative outcomes. Risk is less often viewed in terms of balancing good with adverse outcomes. It is perhaps not surprising therefore that societal views as well as cultural influences have a strong impact in shaping our emotional states. Constant uncertainties over the future, and perceived risks can be viewed as a threat or danger to our safety and well-being and to those closest to us, keeping us at a higher state of vigilance, and further heightening our baseline levels of anxiety. But what does it actually feel like to experience anxiety? Can anxiety be helpful to us in any way? How can anxiety disorders be diagnosed? We will explore these and other questions next. The experience of anxiety. The main types of anxiety and anxiety-related disorders are summarized in Box 2. We will look at diagnosis and diagnostic criteria a little later, but the information provided here should serve as a useful reference as you read further and engage with the activities in sections 3.1 and 3.2. Box 2: Anxiety and anxiety-related disorders. Panic attack. A sudden episode of intense fear and desire to escape, distressing physical symptoms, pounding heart, shortness of breath, sweating, nausea, trembling, can be accompanied by fear of dying, losing control, or going crazy. Anxiety peaks in around 10 minutes, then subsides, occurs in situations that do not involve real danger, leads to overly worrying about additional attacks and temptation to avoid feared situations. Generalized anxiety. Excessive worry, most days, about everyday events or activities, difficulty controlling worry, difficulty relaxing, sleep disturbances, difficulty concentrating, irritability, procrastination. Worry interferes with everyday life. Social anxiety. Persistent fear of social or performance situations, e.g. dating, public speaking, intense fear of negative evaluation by others, fear of being humiliated or embarrassed, avoidance of feared situations or enduring intense distress. Phobias. Intense, persistent, and excessive fears of animals, objects or of enclosed spaces. Agoraphobia. Fear of having a panic attack in a place where escape may be difficult or help unavailable, avoidance of anxiety-provoking situations, e.g. shopping mall, public transport, etc. Obsessive-compulsive disorder, OCD. Characterized by recurring upsetting thoughts, and attempts to deal with these, e.g. compulsions such as hand-washing, arranging items in a particular order, counting, to temporarily relieve anxiety. Post-traumatic stress disorder, PTSD. Anxiety induced after witnessing or being subjected to or experiencing a traumatic event, recent or in the past. Understanding diagnosis key issues. Diagnosis of mental health conditions is commonly based on one or other of two classification schemes. These are, I, the Diagnostic and Statistical Manual of Mental Disorders, currently in its 5th edition, DSM-5, published in 2013 by the American Psychiatric Association, and, 2, the World Health Organization's International Classification of Disease or ICD, which has been revised at the time of writing, ICD-11, which became available on June 18, 2018. You can read about DSM and anxiety in a short paper by David Kupfer from the Department of Psychiatry at the University of Pittsburgh School of Medicine, published in 2015. A link to the article is provided in the references section. There continues to be considerable controversy and debate around the use of one system over the other in mental health research and clinical practice. The ICD was initiated more than 100 years ago as a means to help classify disorders in medicine more generally, and it has been argued that the system also allows greater clinical discretion in making a diagnosis for mental health conditions. Tyrer, 2014. The DSM was specifically developed for mental and behavioral disorders, and its reliability in test-retest situations has continued to improve through subsequent iterations, particularly since its 3rd edition, DSM-3, which was published in 1980. Nevertheless, there continues to be a split between those who adhere to the DSM versus those whose preference is for ICD, and criticisms have been directed against both systems. Tyrer, 2014. Added to the above are further complications. Assessment, diagnosis, and treatment of psychiatric, behavioral and mental health conditions have evolved over many decades around the world, mainly from research carried out in specialist settings such as hospitals and clinics, institutions, as opposed to more natural environments such as within the community. There are differences in approach to diagnosis, e.g. patient-centered versus disease-based, and symptoms may overlap between diagnostic classifications, comorbidity, or may not meet the criteria for a particular disorder, but still require treatment. Taking these issues as well as the views of patient groups and advocates into consideration, there has been a move over recent years, and particularly within the UK, towards a more integrated, individualized or tailored approach to diagnosis and management of mental health that takes the lead from and involves the patient as a service user. Gask et al., 2009. Much of the controversy and ensuing debate around diagnosis has arisen since a clinical diagnosis is not always straightforward. Psychiatric diagnoses have historically been based on presenting symptoms, and to this day psychiatric nosology remains almost exclusively based on presenting signs and symptoms and descriptive taxonomy. Taking anxiety and depressive illness as examples, the first thing to note is the overlap in signs and symptoms between these conditions, termed comorbidity. then there remains a fundamental lack of standardized biological parameters, disease identifiers or biomarkers, that could arguably represent a more objective measure to support clinical diagnosis. Biological and genetic markers which can be used to screen for conditions such as diabetes, cancer, or metabolic diseases, to help identify and delineate a specific disorder or a pathophysiological, i.e. disease, state, continue to remain elusive for most psychiatric conditions. It was anticipated that psychiatric diagnoses in DSM-5 would include, in addition to signs and symptoms, brain imaging, biomarker and genetic data, and in doing so add some measure of sensitivity and specificity to diagnosis, but this has not been realized. Nemiroff et al., 2013. Diagnosis according to the DSM remains phenomenologically based. DSM-5 does, however, have an increased focus on trauma-related and stressor-related disorders, which could lead to increased recognition and understanding of adversities, particularly those that may be experienced during childhood and adolescence. Indeed, one of the biggest shake-ups from the previous edition has been to the classification of anxiety and related disorders. The DSM-5 chapter on anxiety disorder no longer includes obsessive-compulsive disorder, post-traumatic stress disorder, or acute stress disorder. PTSD and OCD in DSM-5. Post-traumatic stress disorder, PTSD, and acute stress disorder have been moved from anxiety disorders to an independent category of trauma and stressor-related disorders or TSRD. PTSD has been traditionally conceptualized as a fear disorder defined by three clusters of symptoms: re-experiencing of fear, intrusive memories, avoidance of the reminders of trauma, amnesia, withdrawal, avoidance of situational reminders, and hyperarousal, disturbances in sleep, heightened startle response. Nemiroff et al., 2013. DSM-5 has moved beyond a fear-based anxiety construct, and PTSD criteria have been revised to include negative emotional states and symptoms of distress, dysphoria, aggression, guilt, and shame on account that those with PTSD, e.g. war veterans and victims of crime or of abuse, often present for clinical assistance with such negative emotional states. A new PTSD subtype introduced for children aged 6 and under is considered to take into account the variation of symptom presentation in young children. DSM-5 also lists obsessive-compulsive disorder and related disorders, OCRDs, as a separate category, along with new conditions such as hoarding disorder and excoriation or skin-picking disorder. The decision was based on a review of evidence suggesting that OCD differs from anxiety disorders on several diagnostic validators and psychobiological and phenomenological overlap between OCD and some related conditions. The close relationship with anxiety disorders is still reflected by the sequential order of corresponding chapters in DSM-5, Nemiroff et al., 2013. An emphasis the potential advantage for clinical practice of segregating PTSD and OCRDs from anxiety-related disorders, was to raise awareness amongst clinicians and the public, of these underdiagnosed and undertreated conditions, encouraging researchers to use structured diagnostic interviews and standardized symptom measures to investigate and evaluate the full range of these conditions in a systematic way. Nemiroff et al., 2013. Critics of the DSM continue to debate the definition and classification of psychiatric disorders, stressing that it is important to avoid medicalizing problems of daily living. Stein et al., 2010, Aptab, 2014. While acknowledging this view, proponents of the DSM stress that those who meet diagnostic criteria for these conditions experience distress or impairment and deserve appropriate intervention. Nemiroff et al., 2013. Criteria that define a mental disorder. At what point does a problem of daily living, or a characteristic human trait, which may lie along the spectrum or continuum of human behavior, become a diagnosable disorder or a disease? When it interferes with an individual's quality of life and causes them distress. But can conditions that are referred to as mental illnesses be truly considered to represent diseases or disorders in a physical sense with an underlying pathology that would qualify their classification as such? Or are they in fact personal, social, and ethical problems associated with everyday living within societal and cultural contexts? Are they psychosocial constructs that reflect the complexity of human interactions, politics, poverty, unemployment, traumatic experiences, internal and external conflict, and the need to conform with societal norms and socially acceptable behaviors? Thomas Szasz, a psychiatrist and lifelong critic of diagnostic classification systems, wrote in his 1960 article on the myth of mental illness. The assumption is made that some neurological defect, perhaps a very subtle one, will ultimately be found for all the disorders of thinking and behavior. For those who regard mental symptoms as signs of brain disease, the concept of mental illness is unnecessary and misleading. For what they mean is that people so labeled suffer from diseases of the brain. Szasz, 1960. 50 years on, in 2011, he wrote, "In due time, with refinements in medical technology, psychiatrists will be able to show that all mental illnesses are bodily diseases. This contingency does not falsify my contention that mental illness is a metaphor. It verifies it. Such a process of biological discovery has in fact characterized some of the history of medicine, one form of madness after another being identified as the manifestation of one or another somatic disease, such as beriberi or neurosyphilis. The result of such discoveries is that the illness ceases to be a form of psychopathology and is classified and treated as a form of neuropathology. If all the conditions now called mental illnesses proved to be brain diseases, there would be no need for the notion of mental illness and the term would become devoid of meaning." DSM-5 criteria that define a condition as a mental disorder. American Psychiatric Association, 2013. A mental disorder is a syndrome characterized by clinically significant disturbance in an individual's cognition, emotion regulation, or behavior that reflects a dysfunction in the psychological, biological, or developmental processes underlying mental functioning. Mental disorders are usually associated with significant distress or disability in social, occupational, or other important activities. An expectable or culturally approved response to a common stressor or loss, such as death of a loved one, is not a mental disorder. Socially deviant behavior, e.g. as political, religious, or sexual, and conflicts that are primarily between the individual and society are not mental disorders unless the deviance or conflict results from a dysfunction within the individual, as described above. The diagnosis of a mental disorder should have clinical utility. That is, it should help to determine prognosis, help in the development of treatment plans, help to give an indication of potential treatment outcomes. A diagnosis of a mental disorder is not equivalent to a need for treatment. A need for treatment is a complex clinical decision that takes into consideration symptom severity, symptom salience, presence of relevant symptom, e.g. presence of suicidal ideation, distress, mental pain, associated with the symptom, disability related to the individual's symptoms, risks and benefits of available treatment. Other factors such as mental symptoms complicating other illness. Note: a DSM-5 clarifies that the diagnosis of a mental disorder does not by itself indicate a need for treatment as outlined above. For Szasz, the notion of mental illness and brain disease appear to be mutually exclusive. Others have argued that the concept of disease can be understood in terms of suffering, functional impairment, and incapacity, and mental disorder conceptualized as transcending the mind-body dualism, Aftab, 2014. It is certainly not as clear-cut as this. Examples from medicine reinforce the point that the health of the body and of the mind are inextricably linked, Renoir et al., 2013, but with the emergence of biological psychiatry and modern advances in brain and behavioral sciences, most mental illnesses are increasingly presumed to have a neurobiological basis, even if that basis is, as yet, poorly understood. This does not address the issue that there is still no satisfactory definition for either disease or mental disorder which is universally accepted, and the term mental disorder is misleading as it implies a distinction between a mental and a physical disorder. DSM-5 has attempted to define the criteria that should be met for a condition to be termed a mental disorder, see Box 3. The global burden. The ICD and DSM classifications have continued to consider mental illnesses as disorders. Indeed, the World Health Organization's Global Burden of Disease Study 2010, the findings from which were released in 2012, indicated that a substantial proportion of the world's disease burden came from mental, neurological, and substance use disorders, 10.4% of global disability-adjusted life years, Dallas, 2.3% of global years lost to premature mortality, YLLs, and 28.5% of global years lived with disability, YLDs. Mental disorders accounted for the largest proportion of Dallas, Whiteford et al., 2015. Anxiety and depressive disorders made a significantly disproportionate contribution to the overall burden of disease. The figures were striking, as detailed below. See also Section 4.4 and Box 9. In their analysis published in 2015, Whiteford and colleagues estimated that anxiety disorders, mild, moderate, and severe states, accounted for more than 272 million cases, derived from estimates of point prevalence, i.e. the number of new and pre-existing cases at a specified point in time, close behind major depressive disorder, at 298 million. These figures were far greater than for other mental, neurological, and substance use estimates, alcohol dependence being next in the order at 95 million, with the exception of tension-type headaches and migraine, which topped the billion mark for prevalence estimates, Table 1 in Whiteford et al., 2015. After standardizing for age, major depressive disorder and anxiety disorders had the highest Dallas with rates for women consistently higher than for men, Table 2 in Whiteford et al., 2015. Aggregating the Dallas across all countries, gender, and age groups for the 2010 data, Table 3 in Whiteford et al., 2015, identified major depressive disorder as representing 2.5%, 63.2 million Dallas, and anxiety disorders 1.1%, 26.8 million Dallas, of all cases of the global burden of disease, and 24.5% and 10.4% respectively of the burden of Dallas attributable solely to mental, neurological, and substance use, the greatest proportions by far in either category amongst the conditions listed. Whiteford and colleagues, 2015, noted that although these disorders exist in all countries, cultures also influence their development and presentation, and that the predominantly Western-based definitions of mental, neurological, and substance use disorders can be in conflict with cultural contexts, leading to challenges in assembling data on global epidemiology, Whiteford et al., 2015. Clearly then, the cultural context in which a diagnosis is made is an important factor for epidemiological studies based on diagnostic classifications. Fortunately, this is acknowledged in DSM-5. Box 4 lists some of the significant changes from the previous edition of the DSM that are relevant to anxiety. Major changes from DSM-4TR to DSM-5 focusing on anxiety disorders. American Psychiatric Association, 2013. One culture is discussed more explicitly to bring greater attention to cultural variations in symptom presentations. 2. DSM-5 has moved to a non-axial documentation of diagnosis, formerly Axes I, 2, and 3, with separate notations for important psychosocial and contextual factors, formerly Axis 4, and disability, formerly Axis V. This approach is consistent with WHO and ICD guidance to consider the individual's functional status separately from their diagnosis/symptom status. 3. Social phobia is now termed social anxiety disorder. 4. Panic disorder and agoraphobia have been unlinked and each now has its own separate criteria, on the basis that many patients experience agoraphobia without panic symptoms. 5. Separation anxiety disorder and selective mutism are now classified as anxiety disorders, instead of disorders of infancy, childhood, or adolescence, which has been eliminated. 6. Age criteria for separation anxiety disorder have been changed to allow onset after age 18, with a duration criterion added of typically lasting 6 months or more. 7. For agoraphobia, specific phobia, and social anxiety disorder, the 6-month duration criterion has been extended to all ages, formerly just individuals under age 18, to minimize overdiagnosis of transient fears. The anxiety must be out of proportion to the actual danger or threat, but the requirement that individuals over age 18 years recognize their anxiety as excessive or unreasonable has been eliminated. 8. Panic attack descriptors have changed to identify unexpected and expected panic attacks. Panic attacks function as a prognostic factor for severity of diagnosis, course, and comorbidity across many anxiety and other disorders, and thus can be listed as a specifier that is applicable to all DSM-5 disorders. The research domain criteria. Further complexities are inherent in the application of existing diagnostic classification systems and their use for different purposes, i.e. research-focused versus clinical practice-based. Given such difficulties, the U.S. National Institute of Mental Health, NIMH, initiated the Research Domain Criteria, RDoC, project in 2009, to align more closely the dimensions of observable behavior with neurobiological measures, as a new way of classifying mental disorders, NIMH, 2017, Cuthbert, 2015, McKay and Tallon, 2016. The aim was to forge new approaches that can translate advances in brain and behavioral science to assessment and treatment, Cuthbert, 2015. This experimental framework was developed mainly for research purposes, not as a clinical tool, but has gained considerable wider interest for its potential use in future psychiatric nosologies, aspiring to add further precision to psychiatric diagnoses, guiding treatment decisions and expected outcomes or course of illness, tailored to an individual. Rather than starting with clinically derived definitions of mental disorders based on presenting signs and symptoms and seeking biological or psychological correlates, RDoC adopts the rather radical approach of first creating a compendium of basic behavioral and cognitive functions and related brain circuits, and considering disorders in terms of dysregulation or dysfunction in these foundational systems, informed by initiatives such as the Human Connectome Project and the U.S. Brain Program, Cuthbert, 2015. You can read the definitions of the 6 RDoC domains and associated constructs on the NIMH website. The sensoromotor domain was added in 2019. RDoC attempts to change the way that mental disorders are conceptualized and studied by acknowledging that mental illnesses are increasingly understood to be disorders of neurodevelopment and that the study of normal development provides a basis for understanding aberrant trajectories at different points along developmental pathways, that environmental events exert profound influences, not only in neurodevelopment, but throughout the life course, and that constructs are dimensional and can be defined in terms of the degree of departure from the normal range, providing the capability of more readily establishing cut-off points to define, for example, mild, moderate, or severe levels of disorder achieving quantitative dimensional measures. But the broader problems of heterogeneity, individual differences, subtypes, symptom clusters and their overlap remain challenging issues, even with the move away from a categorical to a more dimensional, spectrum-based, understanding supported by the new RDoC approach. Thomas Insel, the former NIMH director involved in the launch of RDoC, wrote in 2013, "The strength of each of the editions of DSM has been reliability. Each edition has ensured that clinicians use the same terms in the same ways. The weakness is its lack of validity. Unlike our definitions of ischemic heart disease, lymphoma, or AIDS, the DSM diagnoses are based on a consensus about clusters of clinical symptoms, not any objective laboratory measure. In the rest of medicine, this would be equivalent to creating diagnostic systems based on the nature of chest pain or the quality of fever. Indeed, symptom-based diagnosis, once common in other areas of medicine, has been largely replaced in the past half-century as we have understood that symptoms alone rarely indicate the best choice of treatment. NIMH has launched the Research Domain Criteria (RDoC) project to transform diagnosis by incorporating genetics, imaging, cognitive science, and other levels of information to lay the foundation for a new classification system. He went on to say, it became immediately clear that we cannot design a system based on biomarkers or cognitive performance because we lack the data. In this sense, RDoC is a framework for collecting the data needed for a new nosology. But it is critical to realize that we cannot succeed if we use DSM categories as the gold standard. The diagnostic system has to be based on the emerging research data, not on the current symptom-based categories. Imagine deciding that EKGs were not useful because many patients with chest pain did not have EKG changes. That is what we have been doing for decades when we reject a biomarker because it does not detect a DSM category. We need to begin collecting the genetic, imaging, physiologic, and cognitive data to see how all the data, not just the symptoms, cluster and how these clusters relate to treatment response. Reflection. The issues raised previously, the discussion around diagnosis, provide the relevant backdrop for you to explore etiology and treatments, mindful of the context in which research in these areas will be presented. We will critically examine aspects associated with the etiology of anxiety in the next section, focusing specifically on gender and work-related stress as risk factors. Reflect on your learning in this section. What were the key issues or concepts that stood out for you? How much of the material covered in this section were you already familiar with? Can you offer further or alternative perspectives, drawing on your own personal or professional experience? Exploring anxiety Part 2. We know that anxiety can be a normal adaptive, behavioral and physiological response to stress. The acute fight or flight response can energize, motivate, and increase our focus and attention in the short term. It can operate as a call to action, a self-preservation or survival mechanism that alerts us to steer away from or to face and deal with and resolve a stressful situation, a perceived danger or a threat. This is quite different from chronic, persistent or intense anxiety, which can be related to a specific cause such as a phobia, or anxiety that endures but may be unexplained, an irrational fear or worry. Chronic and persistent anxiety interferes with everyday life, both in terms of the frequency and severity of symptoms, causes worry and distress, and meets diagnostic thresholds, DSM or ICD classifications. When anxiety becomes maladaptive in this way, it has negative consequences on health, becomes debilitating and warrants intervention. Symptoms, behaviors, and negative thoughts. A change in behavior can often be the presenting symptom of anxiety, a response to physiological or psychological stressors. Common symptoms and general behaviors associated with anxiety disorders are listed in Box 5. Cognitive distortions, negative modes of thinking, that can contribute towards and exacerbate anxiety are summarized in Box 6. Common symptoms and general behaviors associated with anxiety disorders. Common symptoms: physical, trembling, muscle tension, shortness of breath, accelerated heart rate, heart palpitations, sweating, dizziness, dry mouth, loss of appetite, nausea, headaches, insomnia. Behavioral and cognitive: avoidance, disturbed sleep, procrastination, turning to alcohol, increased caffeine or nicotine use, distractibility, restlessness, irritability, hypervigilance, repetitive thoughts, negative self-talk, disorientation, thoughts of dying or going insane or out of control, persistent worries, difficulty concentrating, experiencing frightening or intrusive thoughts or images. General behaviors and associated outcomes: feeling overwhelmed, fear of failure, perfectionism, missed or unmet deadlines, low performance, lost relationships, difficulty relaxing, overwhelming spells of panic, avoiding places or situations from which a quick exit is not possible, feeling as though something catastrophic will happen, further concern or distress about own anxiety, negative circle, significant changes in behavior as a result of anxiety, avoiding social interaction or situations, feeling judged, feeling embarrassed. Experiencing intrusive thoughts or repetitive behaviors, can lead to substance use, e.g. alcohol or hard drugs such as cocaine, ecstasy. Marijuana. To cope with anxiety, increased caffeine or nicotine use can further heighten state of arousal and hypervigilance. Box 6. Anxious thinking. Cognitive distortions that can contribute to increased anxiety. Based on Beck, 1964, 1976, and Burns, 1980. All or nothing, seeing things in black and white or right and wrong terms. Disqualifying positives, rejecting positive experiences because they don't count. Jumping to conclusions, drawing negative conclusions even though there is insufficient evidence. Mind reading, arbitrarily deciding you know what negative conclusions others have made about you. Catastrophizing, assuming extreme and horrible consequences of events. Should and shouldn'ts, telling yourself what you should and should not do. Mental filtering, focusing on a single negative detail and dwelling on it. Diagnostic criteria for generalized anxiety disorder and panic disorder. In Section 3 we began to explore some of the complexities associated with the diagnosis of mood disorders, noting the lack of definitive biological, genetic, or brain imaging markers, biomarkers, that could be used to support diagnosis at the present time. Anxiety can coexist with other psychiatric conditions, most notably depression. It can also manifest as a consequence of a somatic complaint, physical illness such as cancer, diabetes, cardiovascular disease, or chronic pain, and may present differently in children and adolescents compared with adults, adding further complication to diagnosis. Generalized anxiety disorder, GAD, and panic disorder, PD, are amongst the most prevalent of anxiety disorders in the world today. You can read further about the diagnosis and management of GAD and PD in the article by Locke et al., 2015. Written from a U.S. perspective aimed at family physicians, i.e. GPS, and those in continuing medical education, Locke and colleagues consider important aspects of diagnosis and management of GAD and PD in adults using the DSM-5 diagnostic criteria, discussed in Section 3.3, which are of wider, global relevance. The link to the article is provided in the references section should you wish to read further on this topic, beyond this course. The DSM-5 criteria for GAD and PD are presented in boxes 7 and 8, APA, 2013, for information. Box 7 DSM-5 Diagnostic Criteria for Generalized Anxiety Disorder. Adapted from Locke et al., 2015, based on APA, 2013, p.222. A. Excessive anxiety and worry, apprehensive. Expectation, occurring more days than not for at least months, about a number of events or activities, such 6. as work or school performance. B. The individual finds it difficult to control the worry. C. The anxiety and worry are associated with 3, or more, of the following 6 symptoms, with at least some symptoms having been present for more days than not for the past 6 months. Note: only one item is required in children. 1. Restlessness or feeling keyed up or on edge. 2. Being easily fatigued. 3. Difficulty concentrating or mind going blank. 4. Irritability. 5. Muscle tension. 6. Sleep disturbance, difficulty falling or staying asleep, or restless, unsatisfying sleep. D. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. E. The disturbance is not attributable to the physiological effects of a substance, e.g. a drug of abuse, a medication, or another medical condition, e.g. hyperthyroidism. F. The disturbance is not better explained by another mental disorder, e.g. anxiety or worry about having panic attacks in panic disorder, negative evaluation in social anxiety disorder, social phobia, contamination, or other obsessions in obsessive-compulsive disorder, separation from attachment figures in separation anxiety disorder, reminders of traumatic events in post-traumatic stress disorder, gaining weight in anorexia nervosa, physical complaints in somatic symptom disorder, perceived appearance flaws in body dysmorphic disorder, having a serious illness in illness anxiety disorder, or the content of delusional beliefs in schizophrenia or delusional disorder. Box 8 DSM-5 Diagnostic Criteria for Panic Disorder. Adapted from Locke et al., 2015, based on APA, 2013, p.208-9. A. Recurrent unexpected panic attacks. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4, or more, of the following symptoms occur. Note, the abrupt surge can occur from a calm state or an anxious state. 1. Palpitations, pounding heart, or accelerated heart rate. 2. Sweating. 3. Trembling or shaking. 4. Sensations of shortness of breath or smothering. 5. Feelings of choking. 6. Chest pain or discomfort. 7. Nausea or abdominal distress. 8. Feeling dizzy, unsteady, lightheaded, or faint. 9. Chills or heat sensations. 10. Paresthesias, numbness or tingling sensations. 11. Derealization, feelings of unreality, or depersonalization, being detached from oneself. 12. Fear of losing control or going crazy. 13. Fear of dying. Note, culture-specific symptoms, e.g. tinnitus, neck soreness, headache, uncontrollable screaming or crying, may be seen. Such symptoms should not count as one of the 4 required symptoms. B. At least one of the attacks has been followed by 1 month, or more, of one or both of the following. 1. Persistent concern or worry about additional panic attacks or their consequences, e.g. losing control, having a heart attack, going crazy. 2. A significant maladaptive change in behavior related to the attacks, e.g. behaviors designed to avoid having panic attacks, such as avoidance of exercise or unfamiliar situations. C. The disturbance is not attributable to the physiological effects of a substance, e.g. a drug of abuse, a medication, or another medical condition, e.g. hyperthyroidism, cardiopulmonary disorders. D. The disturbance is not better explained by another mental disorder, e.g. the panic attacks do not occur only in response to feared social situations, as in social anxiety disorder, in response to circumscribed phobic objects or situations, as in specific phobia, in response to obsessions, as in obsessive-compulsive disorder, in response to reminders of traumatic events, as in post-traumatic stress disorder, or in response to separation from attachment figures, as in separation anxiety disorder. A. Etiology of anxiety disorders and the basic neural circuitry involved in anxiety. The causes of anxiety disorders are complex and multifactorial and can include, among others, psychological trauma, psychosocial stressors, and conflict, as well as physical illness. Current models for GAD point to an underlying dysregulation in the physiological and behavioral responses to stress, which involves the hypothalamic pituitary adrenal axis, and activation of brain networks responsible for threat detection, introspective thinking as well as learning and memory, e.g. conditioned and social learning and social referencing. Twin studies suggest that environmental, e.g. psychosocial, and genetic factors are likely involved. A key brain structure involved in the neural circuitry of anxiety is the amygdala, located within the temporal lobes and forming part of the limbic system regulating mood and emotional responses. Parts of the amygdala are involved in triggering the responses we associate with fear, e.g. submission, fleeing, or freezing on the spot. Other regions within the amygdala elicit feelings of bliss or peacefulness, or evoke aggression and attack. Life or death situations are processed within fractions of a second. To do this, sensory information from the external environment must first reach the amygdala. This is achieved in two ways: a direct route to the amygdala via the thalamus, taking about 1/50th of a second, and an indirect route to the amygdala via the cerebral cortex, which takes slightly longer, about 1/5 of a second, but allows information about the stimulus, its nature, location, threat level, etc., to be consciously processed and an assessment to take place. Interaction between the amygdala, prefrontal cortex, and hippocampus modulates the response, e.g. through assignment of emotional salience, monitoring and detection, and an awareness of the context in which a stimulus is received and any memory or recall of its previous experience or encounter. The main outputs of the amygdala are the hypothalamus, basal forebrain, and brainstem, pathways that elicit the physiological, cognitive, and emotional responses associated with fear and anxiety. In the remainder of this section we explore two key issues: gender and work-related stress as risk factors for anxiety disorders. We specifically ask whether women are more likely to suffer from anxiety than men, and consider whether work is good or bad for your mental health. Are women more likely to suffer from anxiety disorders than men? Before we proceed further, it is important first to establish the concepts of prevalence, incidence, and lifetime prevalence, which are frequently used when figures are quoted for mental health conditions. See Box 9. DALAS and YLDs, which you were introduced to in Section 3, are also defined here for reference. Box 9. Understanding the figures frequently quoted for mental health conditions. Prevalence: the number of people with a particular diagnosis within the population at any given time. Lifetime prevalence: the number of people who have experienced a particular mental health problem at any time in their lives. Point prevalence: the number of new and pre-existing cases at a specified point in time, i.e. the number of people living with a condition within a specified time period, e.g. 1 year, divided by the number of individuals within the population. Incidence: the number of new cases of a particular mental health condition that appear in a specified time period. DALAS: disability adjusted life years, or the sum of years of potential life lost due to premature mortality and the years of productive life lost due to disability. YLDs: years lived with disability. Comparing the number of new cases, incidence, with the number who are ill at any given time, prevalence, can provide a rough indication of the average amount of time a mental health condition is likely to last. Often the number of people treated by health professionals is used to determine how common a mental health problem is, but this is likely to be an underestimate as it does not take into account those who may not have come into contact with services. Psychiatric diagnoses are also not always straightforward, as we have seen, and a person's diagnosis can change during the course of their life, and impact on the treatment that they receive. Examining the figures from the WHO Global Burden of Disease 2010 study. If we look again at the data from the WHO Global Burden of Disease 2010 study, the global burden, Whiteford et al., 2015, we can see that anxiety and depressive disorders not only made a significantly disproportionate contribution to the overall burden of disease, but also ranked highest amongst the neurological, substance use and mental disorders categories, Whiteford et al., 2015. The prevalence of anxiety and major depressive disorders was also highest in regions with a history of conflict or war, including in North Africa and the Middle East, according to the study, Whiteford et al., 2015. The top 10 DALAS attributable to mental, neurological, and substance use disorders. DALAS attributable to the top 10 burdens for mental, neurological, and substance use disorders. Employment can be good for mental health. The Royal College of Psychiatrists, 2017, note that work gives us social contacts and support, a way of structuring and occupying our time, physical and mental activity, an opportunity to develop and use skills, social status, a sense of identity and personal achievement, and monetary and other resources needed for material well-being. Contrary to this, those who are unemployed or out of work for more than 12 weeks are between 4 and 10 times more likely to suffer from depression and anxiety. They generally also have poorer physical and mental health overall, consult their GP more, are more likely to be admitted to hospital, and have higher death rates. Unemployment is also linked with an increased rate of suicide, Royal College of Psychiatrists, 2017. A press release issued by the Department of Health in 2014, based on the UK Chief Medical Officer's, CMO's, annual report of the same year, also noted that employment is good for mental health. Department of Health, 2014a. In the report, Professor Dame Sally Davies made 14 recommendations to improve public mental health services, Department of Health 2014b. The following key points were highlighted in the report. 70 million working days were lost to mental illness at a cost of £70 to £100 billion to the UK economy in the previous year. People with a chronic physical condition, such as a heart condition, have a 2.6-fold increase in the odds of having a mental illness. The number of days lost to stress, depression and anxiety had increased by 24% since 2009. 50% of adult mental illness started before the age of 15, and 75% by the age of 18. 75% of people with diagnosable mental illness received no treatment at all. 60 to 70% of people with common mental health conditions such as depression and anxiety were in work, and more was needed to be done to help people with mental health conditions remain in work. This latter point was emphasized as a stark issue by Professor Davies, stating that it is crucial that we take action to help those people stay in employment to benefit their own health as well as the economy. Department of Health, 2014a. Professor Simon Wesley, President of the Royal College of Psychiatrists at the time, welcomed the report, with its particular emphasis on the importance of employment to good mental health, and endorsed the CMO's call for employment becoming a routine outcome indicator for mental health services, an outcome that has real-world relevance. He further commented that more support is needed to keep those who are at risk of losing their jobs from joining the ranks of the long-term sick. Department of Health 2014a. Work can be a cause for stress, anxiety, and depression. A report published by the Health and Safety Executive, House, in 2016, entitled Work-Related Stress, Anxiety, and Depression Statistics in Great Britain, provided some useful estimates of the extent of work-related illness and annual working days lost in 2015 to 16. The data were collected from the Labour Force Survey, a household survey across Great Britain, where participants self-reported work-related illness over the previous 12 months, and included long-standing and new cases, and the Health and Occupation Research Network for General Practitioners, to assess whether new cases of mental ill health presented in surgeries across Great Britain were work-related and to confirm their cause. Key findings from the report are presented in Box 10. For the latest figures, see the House website. Box 10 Key findings from the House report on work-related stress, anxiety, and depression statistics in Great Britain 2016, House, 2016. Stress, anxiety, and depression accounted for 37% of all cases of work-related ill health and 45% of all working days lost due to ill health in 2015/16. The estimated prevalence and incidence rates have remained broadly comparable with little change for more than a decade. The total number of cases of work-related stress, depression, or anxiety in 2015/16 was 488,000. Prevalence rate of 1,510 per 100,000 workers. The number of new cases was 224,000, incidence rate of 690 per 100,000 workers. The total number of working days lost in 2015/16 due to stress, anxiety and depression was 11.7 million days, an average of 24 days lost per worker. Stress was found to be more prevalent in public service industries, such as education, health and social care, public administration and defense. Healthcare workers, teaching professionals, business, media, and public service professionals all showed higher levels of stress as compared to other occupational groups. The main factors cited by respondents as causing work-related stress, anxiety, or depression were workload pressures, including tight deadlines, excessive responsibility, and a lack of managerial support. A further breakdown of the data showing prevalence figures by industry, occupational group, gender, and age is provided in Tables 3 and 4. Table 3 Prevalence figures, mean number of cases per 100,000, for work-related stress presented by industry and occupational group, adapted from House, 2016. Industries 2016. Mean number of cases per 100,000. Corresponding ratios. Public Administration and Defense. 2030. 149. Human Health and Social Work. 2020. 150. Education. 1780. 156. Average for all industries. 1230. 1:81. Occupational groups 2016. Mean number of cases per 100,000. Corresponding ratios. Welfare professionals. 4,990. 120. Nursing and midwifery. 3,010. 133. Teaching. 2,530. 140. Professional occupations. 1980. 150. Average for all occupational 1231:81. Groups. Table 4 Prevalence figures, mean number of cases per 100,000, for work-related stress segregated by gender and age group over a 3-year period, from 2013 to 14 to 2015 to 16, adapted from House, 2016. Means across all age groups. Mean number of cases per 100,000. Corresponding ratios. Female. 1,820, 60%. 155. Male. 1,190, 40%. 1:84. Means across 3 age groups. Mean number of cases per 100,000. Corresponding ratios. Females 25 to 34 years. 1,790, 29%. 156. Females 35 to 44 years. 2,250, 36%. 144. Females 45 to 54 years. 2,170, 25%. 146. 6,210, total. Males 25 to 34 years. 1,100, 28%. 1:91. Males 35 to 44 years. 1,270, 32%. 1:78. Males 45 to 54 years. 1,590, 40%. 1:63. 3,960, total. Occupational groups with the highest prevalence rates broadly aligned with professions found in the above industries, see Table 3. Welfare, nursing and midwifery, and teaching professions all had statistically significantly higher rates of work-related stress, anxiety, and depression than the rate for all occupational groups combined. House, 2016, see Table 3. The House Report, 2016, p. 3, noted that longitudinal studies and systematic reviews have indicated that stress at work is largely driven by psychosocial factors and is associated with common conditions such as heart disease and anxiety and depression, and may play a role in some forms of musculoskeletal disorders. According to the Labor Force Survey, the predominant causes of work-related stress were workload, in particular tight deadlines, too much work or excessive pressure or responsibility. Other identified factors included lack of managerial support, organizational changes at work, role uncertainty, lack of clarity about job, uncertain about expectations, job insecurity, and low personal control. The General Practitioners Network concluded that workload pressures were the predominant factor for mental ill health, with interpersonal relationships and changes at work representing significant factors. House, 2016. The report concluded that work-related stress, depression, and anxiety accounted for 37% of work-related ill health and 45% of days lost in 2015-16. Occupations and industries reporting the highest rates were consistently in the health and public sectors of the economy. Reasons cited as primary causal factors were also consistent over time, and centered around workload, lack of managerial support and organizational change. Looking at the data presented in Table 4, what can you infer about gender, age, and work-related stress? Between 2013-14 and 2015-16, the mean prevalence rates for females was 1.5 times higher than for males in Great Britain, 1,820 compared to 1,190 per 100,000. The prevalence rates also differed according to age groups between males and females. The prevalence rate was higher for 35 to 44-year-old females compared with 25 to 34 or 45 to 54-year-old females. In contrast, the prevalence rate was higher for 45 to 54-year-old males compared with 25 to 34 or 35 to 44-year-old males. The House report considered that higher rates reported by females is likely a product of the proportion of females in the public services and vocational occupations such as teaching and nursing, and cultural differences in attitudes and beliefs between males and females around the subject of stress. House, 2016, p. 6. Reflect on your learning in this section. What were the key issues or concepts that stood out for you? Were you able to answer either of the questions posed in this section? Are women more likely to suffer from an anxiety disorder than men? Is work good or bad for your mental health? We will pick these questions up again briefly in Section 5 before considering interventions for anxiety. 5. Exploring Anxiety Part 3. At the end of the previous section, you were asked to reflect on the following questions. Are women more likely to suffer from an anxiety disorder than men? Is work good or bad for your mental health? What were your thoughts around these two questions? How did you answer them? In this section, we are going to examine the evidence in more detail, before turning to interventions for anxiety. 5.1 Are women more likely to suffer from an anxiety disorder than men? Revisiting the question. Women, people under the age of 35, and those living with chronic physical conditions are disproportionately affected by anxiety disorders. Remes et al., 2016. The prevalence rates of anxiety disorders in females were almost twice that found for males when data were compared across different countries. Remes et al., 2016. Although a lack of representation from developing and underdeveloped parts of the world could have affected the prevalence estimates, and there is a need for further study of the prevalence of anxiety in these parts of the world, DALAs attributable to anxiety disorders were also 1.9-fold higher in females than in males according to the WHO Global Burden of Disease 2010 study data, Whiteford et al., 2015. The higher rate in females appears to have remained constant between 1990 and 2010, Whiteford et al., 2015. In Great Britain, between 2013-14 and 2015-16, the mean prevalence rate for work-related stress, anxiety, and depression was 1.5 times higher for females than for males, 1,820 compared to 1,190 per 100,000, House, 2016. So evidence from different sources suggests that both prevalence and DALAs attributed to anxiety disorders are higher in women than in men. The UK data suggests there are further disparities in terms of age groups affected. While these data serve as useful indicators, they do not provide any clues as to causation, the direction of the effect, or the extent to which different factors could influence development of anxiety disorders in women. Neither do they offer further insight into differences in the prevalence of different types of anxiety disorders related to gender. Higher prevalence rates in women and younger adults, males and females under the age of 35, could be a result of complex interactions between biological, psychosocial, and lifestyle factors, and susceptibility to anxiety disorders. Claims made for reasons why women have higher levels of anxiety being primarily down to roles as working mothers or linked to the modern-day demands on women that they are more likely to be employed now than in the past, simultaneously looking after family, caring for elderly relatives, managing the household and juggling commitments with work. Mail Online, 2016, need careful scrutiny, and should be supported by research evidence. Without detailed, large-scale, longitudinal studies, where data are gathered over an extended period of time, spanning months to years, and well-controlled comparison studies that take account of confounding factors such as age, diet, lifestyle, marital and employment status, physical and psychological health, family and socio-economic circumstances, e.g. cultural and personal attitudes towards mental health, and help-seeking behaviors. Claims such as this remain speculative. Psychological and biological as well as psychosocial differences between the sexes in the response to stress require further evaluation. Relevant questions include: are women likely to respond to self-reported questionnaires, to disclose and talk about their emotions, and to seek help, and consequently receive a clinical diagnosis, more often than men? Do women and men use the same coping strategies when faced with stress? Are women more likely to internalize their thoughts and be more prone to rumination and anxious or negative thinking than men? Are men more likely to externalize their emotions and to develop other problems, for example by turning more to alcohol or substance use? Could biological differences influence the development of anxiety disorders? What bearing do culture, societal attitudes towards mental health and psychosocial factors have on these perceived differences, e.g. differences between Western versus Far Eastern cultures? Are there key cultural differences between males and females in terms of attitudes and beliefs around the subject of stress and mental health problems? The questions highlighted above emphasize the significant gaps in research that remain. Let's now examine the evidence around work and mental health. 5.2 Is work good or bad for your mental health? Revisiting the question. Work has clear long-term benefits for mental well-being, but can also be a cause of stress, anxiety, and depression. Work-related stress, anxiety, and depression accounted for 37% of work-related ill health and 45% of days lost in Great Britain in 2015-16, House, 2016. Occupations and industries reporting highest rates were consistently in the health and public sectors of the economy, with reasons self-reported as primary causal factors also consistent over time. These centered around workload, lack of managerial support and organizational change, House, 2016. However, it is also worth noting that people with a chronic physical condition, such as a heart condition, have a 2.6-fold increase in the odds of having a mental illness. Around 60 to 70% of people with common mental health conditions such as depression and anxiety are in work, and that up to 75% of people with diagnosable mental illness receive no treatment at all. Department of Health, 2014A and 2014B. So once again, there is no straightforward answer to the question posed. Work can be considered to be good for mental health, but a negative outcome, stress, anxiety, and depression, may depend on a number of factors including, for example, the nature of the work, the profession, the type of work involved, organizational or management structure and stability, job security, the social environment, level of support, individual differences, in temperament and state of physical and mental health, interaction with others, psychosocial and interpersonal levels, other capabilities, e.g. time and self-management, organization, etc., coping strategies, work-life balance, and social and cultural attitudes and beliefs towards work. Once again, significant gaps in research remain. 5.3 Work, Gender, and Mental Health examining issues further. Activities 7 and 8 explore some of the issues a little further. Activity 7 Examining Issues Further Part 1. Allow 30 minutes. Ahead of Mental Health Awareness Week 2016, a survey commissioned by Aviva, an insurance company, found that 24% of a representative sample of the UK adult population living with stress, anxiety, or depression in the past year, did not seek any support. Over a third of people surveyed said that work had contributed to mental health problems, and around a fifth said that juggling work-life balance played a major role in causing stress. Read the 2 articles below, then critically reflect on and answer the questions that follow. Sarah Bean, 2016, Work is most common cause of stress, anxiety, and depression. Aviva, 2016, UK adults accepting mental health issues as the new norm, as many do not seek help for stress, anxiety, and depression. 1. How was the research carried out? What was the sample size? How representative was this of the population as a whole? 2. Amongst the population sampled, what reasons were cited for people not seeking help for mental health problems? 3. What were the most common mental health conditions reported? 4. Were there any gender differences in attitudes towards help seeking? 5. Other than work pressures, were any other issues reported as a significant cause of anxiety and depression? 6. Of those who had experienced a mental health problem, what proportion said that they had successfully recovered from their mental health condition or that it was being effectively managed? View discussion, Activity 7 Examining Issues Further Part 1. Activity 8 Examining Issues Further Part 2. Allow 30 minutes. A study carried out in the United States has found that the odds of generalized anxiety disorder and depression were markedly greater among women who earned less than their male counterparts, with whom they were matched on education and years of experience. The results were published in the peer-reviewed journal Social Science and Medicine, PLAT et al., 2016. The press release issued by Columbia University starts off with the following statement: for every dollar an American man makes, his equally qualified female counterpart makes just 82 cents. Columbia University Mailman School of Public Health, 2016. Inequality in pay is a significant concern, but can a causal relationship with anxiety and depression be established based on this difference alone? Read the 2 articles below, then critically reflect on and answer the questions that follow. Urquhart, 2016, Wage gap could explain why women are more likely to be anxious and depressed than men. Women may internalize wage gap as reflective of perceived inferior merit. Columbia University's Mailman School of Public Health. Columbia University Mailman School of Public Health, 2016, Wage gap may help explain why more women are anxious and depressed than men. 1. Where was the study carried out? Who were the researchers? 2. Who funded the study? Were any conflicts of interest declared? 3. How was the study carried out? What was the sample size? How representative was this of the population as a whole? 4. What were the principal findings of the study? 5. How did the authors interpret these findings? 6. Can a direct causal relationship between disparity in pay and anxiety or depression be established from the findings of this study? Are there any alternative explanations or contributing factors? View discussion, Activity 8 Examining Issues Further Part 2. 5.4 The treatment and management of anxiety disorders. An overview. What may be perceived as stressful to one person is not necessarily always perceived as such by another. People can react to situations in different ways. Let's take a moment to reflect on what we have learned about stress and anxiety. Physical or mental stress can be caused by a variety of external factors, including work pressures from deadlines, work overload, or the loss or change of a job, financial strains, mortgages, bills, debts, unforeseen expenses, unemployment, relationship problems, breakup or divorce, status of one's general health, serious illness, accidents, trauma, and major life events, having children, moving home, getting married, exams, being the victim of a crime or of violence, etc. Anxiety can develop as a result of trauma or significant life events, childhood or past experiences, a complex interplay between biological, genetic, environmental, and psychosocial factors, underlying medical causes, or side effects of certain medications. Physical and mental well-being and personality, temperament, or thinking style can also impact on how anxiety can develop and is maintained. Some of the main forms of treatment and management of stress and anxiety disorders are summarized in Box 11. Box 11 Brief overview of the treatment and management of anxiety disorders. Treatment. Cognitive behavioral therapy, CBT, talk therapy strategies to reduce anxiety, e.g. shifting attitude, managing underlying feelings or emotions such as grief or anger, identifying and modifying catastrophic thinking, exposure therapy, facing your fears. Pharmacological therapies, anxiolytic and antidepressant drugs. Combined therapy, CBT with pharmacological therapy or augmented pharmacological therapies. Management. Making adjustments to lifestyle, eating regularly, keeping to regular sleep schedules, engaging in leisure activities, managing own expectations, avoiding perfectionism, seeking assistance for difficulties, e.g. relationship problems, understanding factors that contribute to, or can trigger, vulnerability, finding healthy ways to deal with feelings, e.g. talking to family and friends, or going for a walk, seeking and accepting professional support, relaxation techniques, e.g. meditation. Visualization, yoga, eschewing. Avoidance of situations or interactions maintains anxiety. Activity 9 Treatments for anxiety. Allow 30 minutes. Listen to the podcast below and consider the questions that follow. You might wish to listen to the entire recording first and review this again, thinking specifically about the questions the second time around. Alternatively, you can consider the questions as you listen to the recording the first time around. Choose whichever approach suits you best. Audio content is not available in this format. View transcript, uncaptioned interactive content. BBC World Service Health Check Anxiety Extract 2. Claudia Hammond from the BBC talks about anxiety, speaking to Claire and Scott about their experiences of anxiety and the effect it has on them, and to Nick Gray, a clinical psychologist from the Centre for Anxiety Disorders and Trauma at the Maudsley Hospital. In London, in this second part of a recording broadcast in 2014, you listen to the first part in Activity 4. 1. In the interview, Claire talks about different treatments that she has been receiving for her social anxiety disorder. What are these? 2. How has Claire come to terms with her anxiety? 3. Scott has also come to terms with his anxiety. How does he manage his anxiety? 4. Both Claire and Scott refer to the amygdala as being affected by treatment. Why is this part of the brain important to understanding anxiety? 5. How does Scott define resilience in the context of anxiety and depression? 6. Nick Gray describes some common precautions that people get into a habit of taking when experiencing severe acute anxiety or a panic attack to try to prevent the worst from happening. What example does he give? 7. Why does he not consider this to be an effective way of managing anxiety? 8. What is exposure therapy and how can it be used for treating social anxiety? 9. Is it possible to rid people of their anxiety? View discussion, Activity 9 Treatments for anxiety. 5.5 Cognitive behavior therapy, CBT, and exposure therapy. CBT is an evidence-based psychological intervention that can be effective for the treatment of anxiety disorders. It is recommended in line with the stepped care approach set out in the National Institute of Health and Care Excellence Guidance, NICE, 2014. CBT identifies connections between feelings, thoughts, and behaviors and develops practical ways to manage patterns of behavior that are causing problems. Exposure therapy is a form of desensitization, which involves gradually exposing the person to the object or situation that they fear, but in a safe and controlled way and working with a therapist. A sense of control, for example, over a phobia can be developed through repeated experiences, but this does need to be carefully managed to avoid causing further distress and relies on close interaction and communication with the therapist. How does CBT work? What does it involve? CBT involves working with a therapist to identify negative thinking patterns and behaviors which may be causing difficulties and finding effective coping strategies to challenge these by, for example, changing the way a person feels about a situation to help them to change their behavior moving forward. Royal College of Psychiatrists, 2013, updated in 2015. This psychological therapy is based on the concept that the way we think about a situation can influence our emotions and subsequent behaviors. If we perceive or interpret a situation in a negative light, then the experience associated with it is likely to lead to negative emotions, which in turn can lead to the development of certain types of behaviors or actions. Negative thinking patterns, or cognitive distortions, see Section 4, often start during childhood, and over time, assumptions can be reinforced until as an adult they can frequently interfere with and affect the way an individual feels in their everyday life. See Figure 1. Figure 1 Model of Anxiety based on Beck's Cognitive Triad Model, Beck, 1976. If negative interpretations of situations are not challenged, the patterns of thoughts, feelings, and behaviors can be repeated as part of a debilitating and unpleasant cycle. See Figure 2. Figure 2 Anxiety as a perpetual negative cycle. CBT can help make sense of overwhelming problems by breaking them down into smaller parts, allowing connections and how they affect an individual to become clear. The 5 main areas of assessment that impact on each other are indicated in Figure 3. For example, how you think about a problem can affect how you feel physically and emotionally. Figure 3 5 areas of assessment for CBT. Based on the Royal College of Psychiatrists, 2013. CBT can help break the vicious cycle of altered thinking, feelings and behavior, by helping the individual to recognize and alter their behavior. CBT can be administered individually by a therapist, usually between 5 to 20 sessions, within a group, or via a self-help book or online. CBT typically concentrates on addressing current problems, but the therapist may also ask questions about past experiences to understand how these may be affecting the person in the present. Problems are broken down and addressed in separate elements, see Figure 3. Keeping a diary can help identify patterns of thoughts, emotions, physical feelings, and actions, and the therapist will work with the individual to explore those that are unhelpful or unrealistic, and how they can be changed through practice by, for example, questioning a self-critical or upsetting thought or an action that would have a negative impact and make the individual feel worse, and replacing these with more helpful ones. A course of CBT can last a few weeks or up to 6 months. It depends on the nature of the problem and how the therapy works for the individual. It is not a quick fix, and may not be for everyone, and there is the possibility that symptoms of anxiety may return, so practicing the skills learned, i.e. as part of homework outside of therapy sessions, is important, and undertaking further courses of therapy may be required. CBT can also be combined with medication, anxiolytic or antidepressant drugs, to treat anxiety. Other psychological therapies include interpersonal therapy, IPT, and psychodynamic psychotherapy. Anxiety may also be managed through mindfulness-based stress reduction and exercise. The NHS UK website also lists a number of mental health apps that may be of interest. 5.6 Pharmacological therapies. 7 broad categories of medications can be used to manage the symptoms of anxiety. These are selective serotonin reuptake inhibitors, SSRIs, serotonin and noradrenaline reuptake inhibitors, SNRIs, monoamine oxidase inhibitors, MAOIs, tricyclic antidepressants, TCAS, benzodiazepines, tranquilizers, anticonvulsant drugs, e.g. pregabalin, beta blockers, e.g. propranolol. SSRIs, SNRIs, MAOIs, and TCAS can be effective for treating anxiety, but are also used for treating depression and are commonly referred to as antidepressant medications. They have varying degrees of unwanted side effects. SSRIs and SNRIs are most commonly prescribed as front-line pharmacological treatment due to fewer side effects than MAOIs and TCAS. Benzodiazepines may be prescribed for severe or disabling anxiety, but are less frequently used due to long-term dependence. They are instead typically used as a short-term temporary measure, for example, during crises, in cases where anxiety does not effectively respond to CBT, or to other anxiolytic medications. An anticonvulsant drug such as pregabalin, normally used to treat epilepsy, may also be prescribed to treat certain anxiety disorders, e.g. for generalized anxiety disorder. Beta blockers can help to manage the physical symptoms of anxiety, such as rapid heartbeat, palpitations, and tremor, and can be helpful for specific phobias, e.g. getting on an aeroplane, or situations that induce social anxiety, such as performance anxiety or public speaking, but are not thought to address psychological symptoms directly. Table 5, based on Locke et al., 2015, provides a summary of medications that may be used in the treatment of generalized anxiety disorder and panic disorder. SRIs, SNRIs, and MAOIs work by prolonging the activity of the neurotransmitters serotonin and noradrenaline, which are involved in regulating mood, within defined pathways in the brain. SSRIs, developed in the 1980s, specifically prolong the action of serotonin at synapses, the junctions between nerve cells, by preventing its reuptake back into the nerve cells that released it, where it would normally be broken down and recycled. SNRIs, developed in the 1990s, act on noradrenaline as well as serotonin, and are sometimes used for more severe anxiety as well as for depression. TCAS were developed in the 1950s, and their name, tricyclic, reflects their chemical structure, which is composed of 3 rings, tri meaning 3, cyclic meaning ring form or circular. They also prolong the action of noradrenaline and serotonin but have more severe unpleasant side effects than SSRIs or SNRIs. MAOIs prevent the breakdown of noradrenaline and serotonin by inhibiting the action of the enzyme, called monoamine oxidase, responsible for this process, but side effects can be severe and interactions with certain foods mean that a careful diet needs to be followed if prescribed, i.e. in instances where other anxiolytic medications have not worked. Table 5 medications used for the treatment of generalized anxiety disorder and panic disorder, adapted from Locke et al., 2015. First-line medications. Selective serotonin reuptake inhibitors, SSRIs. Escitalopram, Lexapro. Fluoxetine, Prozac. Fluvoxamine. Paroxetine, Paxil. Sertraline, Zoloft. Serotonin noradrenaline reuptake inhibitors, SNRIs. Duloxetine, Cymbalta, B. Venlafaxine, extended release, Effexor XR. Second-line medications. Tricyclic antidepressants, TCAS. Amitriptyline. Imipramine, Tofranil. Nortriptyline, Pamelor. Anticonvulsants. Pregabalin, Lyrica, B. Third-line medications. Monoamine oxidase inhibitors, MAOIs. Isocarboxazid, Marplan. Phenelzyme, Nardil. Tranylcypromine, Parnate. Augmentation. Benzodiazepinisk. Alprazolam, Xanax. Clonazepam, Klonopin. Diazepam, Valium, B. Lorazepam, Ativan. Notes: medications listed in order of most to least commonly used. A. Can be used for panic disorder. B. Can be used for generalized anxiety disorder. C. Benzodiazepines can be used together with other medications as part of augmentation therapy during acute treatment. Dependence, tolerance, and escalating doses to obtain the same effect over long-term use can be problematic, therefore short-term prescription and emphasis on acute management of uncontrolled anxiety is advised. Also, short-acting benzodiazepines such as alprazolam are not preferred due to higher risk of addiction and adverse effects. Conclusion. Use the visual summary below to reflect on your learning for this course, and on the topic of anxiety. What were the key issues or concepts that stood out for you? Figure 4 Visual Summary Anxiety. We have provided you with a larger version of this image in PDF format. This graphic illustration brings together many of the key themes discussed on the topic of anxiety in this course. Use the summary to reflect on your learning for this topic. References. APTAB, A. 2014, Mental Illness vs. Brain Disorders, From ZAS to DSM-5, Psychiatric Times, February 28. Available online at http://www.psychiatrictimes.com/dsm-5-0/mental-illness-vs-brain-disorders-ZAS-DSM-5, accessed April 7, 2019. Alvarez, A.S., Pagani, M., and Musi, P. 2012, The Clinical Application of the Biopsychosocial Model in Mental Health, A Research Critique, American Journal of Physical Medicine and Rehabilitation, Vol 91, No. 2, Supplement, pages S173-S180. American Psychiatric Association, 2013, Diagnostic and Statistical Manual of Mental Disorders 5th edition DSM-5, Arlington, VA, American Psychiatric Association, p.20. Aviva UK Health, 2016, UK adults accepting mental health issues as the new norm as many do not seek help for stress, anxiety, and depression, May 10. Available online at https://www.aviva.com/newsrooms/news-releases/2016/05/UK adults accepting mental health issues as the new norm as many do not seek help for stress, anxiety and depression 17621/. Accessed April 7, 2019. Bean, S., 2016, Work is Most Common Cause of Stress, Anxiety, and Depression, Insight Publishing, May 11. Available online at http://workplace-insight.net/workers-not-getting-help-stress-anxiety-depression, accessed April 7, 2019. Beck, A.T., 1964, Thinking and Depression, Archives of General Psychiatry, Vol 10, pages 561 to 571. Beck, A.T., 1976, Cognitive Therapy and the Emotional Disorders. New York, International Universities Press. Benning, T.B., 2015, Limitations of the Biopsychosocial Model in Psychiatry, Advances in Medical Education and Practice, Vol 6, pp. 347 to 352. Bithell, C., 2010, Mental Health Research in the Media. Recommendations for a New Function at the Science Media Center, Science Media Center Consultation Report. Available at http://www.sciencemediacenter.org/wp-. Content/upload/2012/09/Science Media Center Mental Health Consultation Report.pdf, accessed April 7, 2019. Bithell, C., 2013, Review of the First 3 Years of the Mental Health Research Function at the Science Media Center, Science Media Center Publication. Available at http://www.sciencemediacenter.org/wp-. Content/upload/2013/03/Review of the First 3 Years of the Mental Health Research Function at the Science Media Center.pdf, accessed April 7, 2019. Burns, D., 1980, Feeling Good, The New Mood Therapy. New York. Morrow. Cuthbert, B.N., 2015, Research Domain Criteria, Toward Future Psychiatric Nosologies, Dialogues in Clinical Neuroscience, Vol 17, No. 1, pages 89 to 97. Available online at https://www.dialoguescence.org/content17-1/dialoguesclinurosi17-89/ access 04. July 2019. Deacon, B.J., 2013, The Biomedical Model of Mental Disorder, a critical analysis of its validity, utility, and effects on psychotherapy research, Clinical Psychology Review, Vol 33, pages 846 to 861. Department of Health, 2014a, CMO's Annual Report, Employment is Good for Mental Health, press release. Available online at https://www.governmentuk/government/news/CMO's Annual Report Employment is Good for Mental Health, accessed April 7, 2019. Department of Health, 2014b, Chief Medical Officer, CMO, Annual Report, Public Mental Health. Available online at https://www.governmentuk/government/publication/Chief Medical Officer CMO Annual Report Public Mental Health, accessed April 7, 2019. Engel, G.L., 1977, The Need for a New Medical Model, A Challenge for Biomedicine, Science, Vol 196, pages 129 to 36. Gask, L., Lester, H., Kendrick, T. and Pebbler, R., 2009, What is Primary Care Mental Health? Chapter 1, in Gask, L., Lester, H. Kendrick, T. and Pebbler, R., eds, Primary Care Mental Health, London, R.C. Psych Publications, pages 3 to 15. Health and Safety Executive, House, 2016, Work-Related Stress, Anxiety, and Depression Statistics in Great Britain 2016. Available online at https://web.archive.org/web/20170928012943/http://www.house.gov. UK/statistics/causes/stress/ accessed April 7, 2019. Insel, T. 2013, Transforming Diagnosis, post by former NIMH Director, April 2019, 2013. Available at https://www.nih.nih.gov/about/directors/thomas insel/blog/2013/transformingdiagnosis.html, access 04-07. 2019. Kupfer, D. 2015, Anxiety and DSM-5, Dialogues in Clinical Neuroscience, Vol 17, No. 3, pages 245 to 46. Available online at https://www.nspi.nlm.nih.gov/pmc/article/pmc4610609/. Accessed April 7, 2019. Locke, A.B., Kirst, N., and Schultz, C.G., 2015, Diagnosis and Management of Generalized Anxiety Disorder and Panic Disorder in Adults, American Family Physician, Vol 91, No. 9, pages 617 to 24. Available online at http://www.aafp.org/afp/2015/0501/p617.html. Accessed April 7, 2019. Spencer, B. 2016, Modern Life is Leaving Women Twice as Likely to be Stressed as Men as They Juggle Work, Family, and Children, Daily Mail/Mail Online 6 June. Available online. http://www.dailymmail.co.uk/news/article-3626688/modern-life-leaving-women-twice-likely-stressed-men-struggle-work-family-children.html, accessed April 7, 2019. McKay, D., and Tollin, D.F., 2016, Empirically Supported Psychological Treatments and the Research Domain Criteria, RDoC, Journal of Affective Disorders, PI, S0165-0327, 16, 30656-5. doi, 10.1016/j.jad.2016.10.018. National Institute of Health and Care Excellence, NICE, UK, 2014, Quality Standard QS53 Anxiety Disorders. Available online at https://www.nice.org.uk/guidance/QS53/chapter/quality statement. 2 Psychological Interventions, accessed April 7, 2019. National Institute for Health and Care Excellence, NICE, UK, 2019, Anxiety Guidelines, Pathways, Quality Standards, and Advice. Available online at https://www.nice.org.uk/guidance/conditions and diseases/mental health and behavioral conditions/anxiety, accessed April 7, 2019. National Institute of Mental Health, NIMH, USA, 2017, Research Domain Criteria RDoC. Available online at https://www.nih.nih.gov/research-priorities/RDoC/index.html. Accessed April 7, 2019. Nemiroff, C.B., Weinberger, D., Rutter, M., Macmillan, H.L., Bryant, R.A., Wesley, S., Stein, D.J., Parianti, C.M., Siemler, F., Burke, M., Molly, G.S., Preissig, M., Brune, M. and Lysaker, P., 2013, DSM-5, a collection of psychiatrist views on the changes, controversies, and future directions, BMC Medicine, Vol 11, Article 202. Available online at https://bmcmedicine.biomedcentral.com/articles/10.1186/1741. 7015-11-202, accessed April 7, 2019. NHS Choices, 2016, Women are more likely to suffer from anxiety than men. Available online at http://www.nhs.uk/news/2016/06 June/pages/women-are-more likely-to-suffer-from-anxiety-than-men.aspx, accessed April 7, 2019. Platt, J., Prince, S., Bates, L., and Keyes, K., 2016, Unequal Depression for Equal Work? How the Wage Gap Explains Gender Disparity in Mood Disorder, Social Science, and Medicine, Vol. 149, pages 1-8. Available online at https://www.nspi.nlm.nih.gov/pmc/articles/pmc48011117/. Accessed April 7, 2019. Remes, O., Brain, C., Vanderlinde, R., and La Fortune, L., 2016, a systematic review of reviews on the prevalence of anxiety disorders in adult populations, brain and behavior, Vol. 6, Number 7, Article E00497. Available online at http://onlinelibrary.wiley.com/doi/10.02/brb3.497/abstract. Accessed April 7, 2019. Renoir, T., Hospi, K., and Gray, L., 2013, Mind and Body, How the Health of the Body Impacts on Neuropsychiatry, Frontiers in Pharmacology, Vol. 4, Article 158. https://www.nspi.nlm.nih.gov/pmc/article/pmc3866391/ Accessed April 7, 2019. Royal College of Psychiatrists, 2013, Cognitive Behavioral Therapy. Available online at https://web.archive.org/web/2018/http://www.rcpsych.ac.uk /mental-health-information/therapy/cognitive behavioral therapy.aspx, accessed April 7, 2019. Royal College of Psychiatrists, 2015, Cognitive Behavioral Therapy. Available online at https://www.rcpsych.ac.uk/mental-health/treatments-and-well-being/cognitive behavioral therapy. CBT, accessed April 7, 2019. Royal College of Psychiatrists, 2017, is work good for your mental health? Available online at https://web.archive.org/web/2018/038061447/http://www.rcpsych.ac.uk/useful resources/work and mental health/worker/is work good for you.aspx, accessed April 7, 2019. Sass, T.S., 1960, The Myth of Mental Illness, American Psychologist, Vol. 15, pages 113-8. Available online at http://homepage.westmont.edu/bsmith/documents/zas.pdf. Accessed April 7, 2019. Sass, T.S., 2011, The Myth of Mental Illness, 50 Years Later, Psychiatrist, Vol. 35, pages 179-82. Available online at https://www.cambridge.org/core/journal/thepsychiatrist/article/ Myth of Mental Illness 50 Years Later/4B7C03777C7DF9B49E72B8B740E6B87D8 number, accessed 04. July 2019. Stein, D.J., Phillips, K.A., Bolton, D., Fulford, Kilowatt, Sadler, J.Z., and Kendler, K.S., 2010, What is a mental/psychiatric disorder? From DSM-4 to DSM-V, Psychological Medicine, Vol. 40, number 11, pages 1759-65. Available online at https://www.cambridge.org/core/services/AOPCambridge_SMV.pdf/what_is_DSMV.pdf, accessed April 7, 2019. Tyrer, P. 2014, A Comparison of DSM and ICD Classifications of Mental Disorder, Advances in Psychiatric Treatment, Vol. 20, number 4, pages 280-85. Whiteford, H. A., Ferrari, A. J., Degenhardt, L., Feigen, V., and Voss, T. 2015, The Global Burden of Mental, Neurological, and Substance Use Disorders, an analysis from the Global Burden of Disease Study 2010, +1, Vol. 10, number 2, article E01168220. Available online at http://journals.plos.org/ploson/article, ID equals 10.1371/journal.pon.01. 16820, accessed April 7, 2019. Weir, K. 2012, The Roots of Mental Illness. How much of mental illness can the biology of the brain explain? Monitor on Psychology, Vol. 43, Number 6, p. 30. American Psychological Association. Available at http://www.apa.org/monitor/2012/06/roots, access 04-072019. Solutions. Activity 1, Reflecting on Common Misconceptions. Discussion. It's more than a simple matter of awareness or of public perception. Different perspectives and insight gained through personal as well as professional experiences are important to understanding mental illness, and those who are affected by, and living with mental health conditions. The way we perceive an issue, in what light we view a particular topic, greatly influences our thoughts and behaviors, and how we relate to, understand or come to terms with our own and other people's experiences. We can see things from positive, negative, or neutral viewpoints. Mental ill health is clearly an emotive, deeply personal, and sensitive discussion area. A better understanding of the issues, the scientific and clinical backdrop to headline news, a closer examination of the evidence, which is often controversial, and informed debates around key issues, will help to dispel misconceptions and misunderstanding, and eliminate stigma. Back to Activity 1, Reflecting on Common Misconceptions. Activity 3, The Experience of an Anxiety Disorder and Panic Attacks. Discussion. 1. She states that she has a form of obsessive-compulsive disorder that causes her to become anxious or frightened when something wrong or unexpected happens. She also suffers from panic attacks, and intrusive anxiety-provoking thoughts. 2. Her anxiety can manifest in different physical and emotional responses, one of which is panic attacks. 3. She describes herself as being really shy and awkward as a teenager, and obsessive-minded as a child. 4. She notes on and off issues with both anxiety and depression, prone to depression, and that she was anxious, awkward, obsessive, and sometimes depressed. 5. Through meeting people with similar interests, opening up and talking to people about her feelings. 6. Her symptoms were exacerbated by the concussion. They became severe and worsened considerably. She refers to her anxiety and obsessive tendencies metaphorically as basically being given steroids by the concussion. Intrusive thoughts predominated. She was angry, she was not eating or sleeping, and her marriage was adversely affected. Thinking about her situation and changing her habits made things worse, giving her further anxiety, leading to panic attacks. She was diagnosed with severe OCD. 7. She defines a panic attack as a sudden episode of intense fear that triggers severe physical reactions when there is no real danger or apparent cause. Panic attacks can be very frightening. When a panic attack occurs, you might think you're losing control, having a heart attack, or even dying. 8. Through a combination of medication and therapy, which is still being figured out, she describes this as a dance given the difficult nature of finding the right combination that would work best. She still experiences panic attacks, but these are fewer and further in between. 9. She says the best thing someone can do is to be there and let the person experiencing the panic attack know that they are there for them, and that they will support them, a comforting presence that will help ride out those waves of panic. Back to Activity 3, The Experience of an Anxiety Disorder and Panic Attacks. Activity 4, Understanding Anxiety Key Issues. Discussion. 1. Around 1 in 14 people around the world are thought be affected by an anxiety disorder at any time. 2. Nick Gray describes it as a kind of feeling of worry, fear, nervousness that people would have about something that has got an uncertain outcome. 3. For him, i.e. from his perspective and subjective experience, that generalized feeling of worry at the back of his mind, worrying about negative outcomes, pessimistically anticipating the worst, is in some ways the milder form of anxiety, whereas acute onset panic attack and phobias, he has a fear of flying, are more debilitating. He describes his experience of the symptoms of phobia, his fear of flying, to be similar to a panic attack, terrifying and uncomfortable. He describes the symptoms as losing the ability to think straight, starting to sweat, to hyperventilate, feeling like you can't get enough breath, as though your chest is constricting, and suffering from gastric distress. For Nick Gray explains that anxiety is a survival mechanism that can help to keep us and those we care about safe. This is a short-lived response that helps us adapt to a situation, quite different from the disabling and chronic anxiety problems that Claire and Scott describe. Similarly, phobias serve a basis through evolution, to help us to prepare against things that could potentially cause us harm, dangerous animals, snakes, spiders, germs, etc. While we have evolved to feel a degree of anxiety that can be considered beneficial, phobias can also develop following traumatic events, and an anxiety response can be associated with traumatic experiences. Scott refers to Darwin's theory that fear enhances the chances of survival of a species, and if we had not developed the fight or flight response through evolution, we as a species would probably have gone extinct long ago, so some quotient of anxiety is highly adaptive. Note that this is also referred to as state anxiety. 5. Scott explains, based on the research for his book, that going back to Greece in the 4th century BC, Rome in the 2nd century AD, or the Renaissance, Victorian or Georgian eras, there are accounts of anxious, miserable, melancholic people, and that every age presumes it is the most anxious age ever, so there is some quotient of anxiety that is relatively fixed throughout the human population and is enduring, i.e. a percentage of the population will tend to be more anxious than others. But there is an argument that certain eras, including the Industrial Revolution, which saw rapid technological change, where the economy is uncertain, where there is rapid social transformation, and changing ideas of gender, are more productive of anxiety and feelings of uncertainty. 6. This is a difficult question to answer given that there is so little evidence to go by outside of the Western Hemisphere, as Nick Gray says in the extract. There is very little research outside of America, Western Europe, and Australia to be able to address this question. A lot of the work has focused on community studies. 7. Scott explains that his mother had emetophobia, phobia of vomiting, and he thought he had acquired his own phobia from seeing her worries, but that his own 7-year-old daughter developed the phobia, which as far as he is aware was independent of having seen him express his own worries. Although this is certainly not conclusive, he does allude to the fact that there may be a genetic influence or predisposition. Nick Gray explains that there is a genetic propensity to have an anxious temperament. This is also referred to as trait anxiety, and life experiences and traumatic events add to this. 8. Nick Gray describes this as being where a person's worst fears are about showing signs of anxiety or saying or doing something that would be embarrassing or humiliating, and then other people thinking badly of them. 9. Claire says she worked with very strong characters who were a lot louder and more expressive than her, and she felt under social pressure to compete. It felt as though she was back at school, in classrooms, and just couldn't be herself. She was worried about speaking to certain people in the office, and showed physical symptoms of anxiety, not sleeping, developing a tremor, heart palpitations, difficulty breathing, which made her progressively more ill. The fact that this was a recurrent experience which she had first had as a child is significant. 10. Given the chronic disabling symptoms and negative experiences, you would perhaps think not. Nick Gray does point out, however, that people may develop personal growth from their experiences, overcome adversity, and develop greater levels of empathy and compassion for others who are also experiencing similar difficulties. Back to Activity 4. Understanding anxiety key issues. Activity 5. Are women more likely to suffer from an anxiety disorder than men? Discussion. 1. It was carried out by researchers based at the University of Cambridge and Westminster City Council, and funded by the UK National Institute for Health Research. 2. The study found that women, people under the age of 35, and those living with chronic physical conditions were disproportionately affected by anxiety disorders. Women were found to be almost twice as likely to be affected as men across different countries. However, the lack of representation from developing and underdeveloped parts of the world and the need for further study of the prevalence of anxiety in these parts of the world were pointed out by the researchers. 3. It was a systematic review, a synthesis of medical research evaluating relevant previously published studies, based on minimum quality criteria for inclusion. The research aimed to collate evidence from previous studies looking at the prevalence of anxiety and global burden across subgroups within the population. Studies that were included varied widely in their methods and populations examined. Due to this variation, the researchers did not carry out a meta-analysis, a method that would have combined the results of individual studies, which would have provided a more robust analysis. They reported findings across individual studies instead. 4. 3 literature databases, up to May 2015, were searched to identify previous systematic reviews and meta-analyses that had reported the burden of anxiety across the globe. The search covered all anxiety disorders including generalized anxiety disorder, social anxiety, and obsessive-compulsive disorder, and methods used to assess anxiety. The researchers focused their search to look for reviews that included individuals suffering from other medical or mental health conditions, chronic or infectious disease, psychiatric conditions, and addiction, as well as those from vulnerable populations. Reviews on the treatment of anxiety were excluded. 2 researchers assessed the quality of the reviews and eligibility for inclusion, and extracted data. 48 studies were gathered to describe the global distribution of anxiety disorders. Selected reviews included studies of people of all ages, from young children to people of old age, with the overall number of studies and individual study sample sizes varying. Methods of assessment of anxiety varied between studies, from structured and unstructured interviews to self-reported questionnaires. 5. The prevalence of anxiety disorders within the population ranged from 3 to 25%. Women were found to be twice as likely to be affected as men, female-male ratio of 1.9 to 1. This was consistently the case across different countries and coexisting health conditions. Young adults under the age of 35 were also more often affected, 2.5 to 9.1%. North America, North Africa, and the Middle East were found to have the highest prevalence, 7.7%, 6.8%, and 7.7% respectively, and East Asia had the lowest prevalence, 2.8%, of anxiety disorders. The researchers found that prevalence was specifically higher in individuals who had chronic physical conditions such as cardiovascular disease, cancer, diabetes, and respiratory diseases, 1.4 to 70%. 6. They stated that important areas of research remained under-investigated or unexplored, and although further studies on the prevalence of anxiety disorders were needed, the findings could serve to guide the research agenda and help develop timely interventions. 7. The study provides a general picture of the prevalence of anxiety disorders worldwide, but does not specify differences between types of anxiety disorder. Anxiety disorders were found to be common across all population groups, but women and young people seemed to be disproportionately affected. Although prevalence was higher in individuals with chronic conditions, there was no indication whether anxiety disorders were considered to be a contributing factor or a consequence of these conditions. The researchers highlighted the large variability in the methods of the reviews and the studies they included, which makes the comparison of prevalence figures between the studies difficult. There was wide variation between reviews in number of studies they included and their sample sizes, 2. the ages of participants, with some reviews focusing on adults and others on children, 3. the population samples, general population samples or those with specific physical or mental health conditions, 4. the assessment of anxiety, and having accounted for confounding factors, i.e. whether the studies took account of other health, environmental or lifestyle factors that may have impacted on the outcomes being measured. 8. The review serves as a useful indicator of the prevalence of anxiety disorders, but cannot be taken to suggest causation. The higher prevalence in women or younger adults could be due to a complex interaction of biological, psychosocial, and lifestyle factors. However, the direction of the effect or the extent of influence of different factors remains unknown. The researchers call for further studies to be carried out on the course of the illness, and note the need for research in developing and underdeveloped parts of the world, and for specific study into vulnerable subgroups of society. 9. No. The claim is based on opinion rather than evidence presented in the study. The Mail Online's claim that the reason why younger women had higher levels of anxiety was down to being working mothers is not warranted, i.e. not supported by evidence, from the study. Back to, Activity 5. Are women more likely to suffer from an anxiety disorder than men? Activity 6. Reflecting on the significance of work to well-being. Discussion. Work can have both positive and negative impacts on our mental state and well-being. Work and employment can be significant in terms of defining who we are, our confidence, self-esteem and personal development. It can help us build relationships and develop our skill sets, and the financial rewards are helpful. However, work-related stress, and difficulties at work, including problems with coworkers, can also lead to mental distress. Back to, Activity 6. Reflecting on the significance of work to well-being. Activity 7. Examining issues further. Part 1. Discussion. 1. This was an online survey carried out by ICM Research in August 2015, for Aviva UK Health. The methodology section of the press release issued by Aviva states that respondents were invited from ICM's online panel and 2004 interviews were conducted amongst a nationally representative sample of the UK adult population. From this information alone, and without a further examination of the sample data, the demographic characteristics or clinical diagnoses of the 2004 respondents, it is unclear in what respects they were considered a nationally representative sample of the UK adult population. The figures quoted, based on this sample population, have been extrapolated to the general population as population estimates by single year of age and sex for local authorities in the UK, mid-2014. According to the survey, 24% of the 2004 respondents, 481 people, aged 18 and over reported having suffered from stress, anxiety, or depression in the past year but had not sought help. The report extrapolates this figure to 12 million, i.e. 24% of the 50,909,098 UK adult population in 2014, so a major headline in the news item and press release, claiming that 12 million UK adults suffered from stress, anxiety, or depression in the past year and did not seek help turns out to be an estimate based on a relatively small sample population, and not an actual statistic. Proportionally, the sample size, 2004 respondents, represents 0.004% of the UK population figure quoted, 50,909,098, so the percentages reported need to be considered in this context. 2. Stigma associated with having a mental health problem and embarrassment were cited. 32% of those surveyed reported that they would be too embarrassed to tell people if they had a mental health issue. For those who had previously experienced mental health problems, this figure was even higher, 42%. 3. Stress, 33%, anxiety, 29%, and depression, 23%, were the most common mental health conditions experienced in the past year. More than half, 55%, of those who reported stress did not seek support, while just under half, 48%, did not seek help for anxiety. Although more people took action on depression, 29% said they did not ask for support. For according to the data provided, men were less likely than women to seek help for anxiety, 51% vs 53%, or depression, 69% vs 73%, whereas men were more likely to seek help for stress, 48% vs 43%. 5. Work pressures were cited as the most common cause, 34%. Financial concerns, worries over money, were also reported as a main cause for those with anxiety, 27%, or depression, 28%, 21% said financial concerns were a significant cause of stress. Juggling work-life balance, 20%, reportedly had a significant role in causing stress, whereas relationship difficulties, 25%, and body image, 21%, were reported as contributing to depression. Poor body image was a notable cited cause for depression amongst 18 to 24-year-olds, 37%. 36% had successfully recovered, and 35% said their condition was being managed effectively. However, 17% did not feel they were getting the right treatment. Back to Activity 7 Examining Issues Further Part 1. Activity 8 Examining Issues Further Part 2. Discussion 1. The study was carried out in the United States by researchers at Columbia University's Mailman School of Public Health. Catherine Keyes, Assistant Professor of Epidemiology, was the senior author. Co-authors, Seth J. Prince, Lisa Bates, and Jonathan Platt, were all based in the Department of Epidemiology at Columbia University. 2. The work was supported in part by a National Institutes of Mental Health Psychiatric Epidemiology training grant. No conflicts of interest were reported by the authors. 3. The findings were based on survey data from a 2001-2002 U.S. population representative sample of 22,581 working adults in America aged 30 to 65. The researchers tested the impact of structural wage disparities on depression and anxiety outcomes, according to criteria in the Diagnostic and Statistical Manual, version 4, DSM-4. From the press releases, it is unclear where the sample was derived, across one or more counties or states, and in what ways the sample was considered representative of the U.S. population, demographic information, so it would be useful to follow up on this by looking at the published study, Platt et al., 2016. The fact that diagnostic criteria were used to assess mental health outcomes, rather than reliance on self-reports alone, suggests a degree of rigor to the methodology. 4. The overall odds of past year anxiety were more than 2.5 times higher for women than for men. Where women's income was lower than their male counterparts, matched for education and years of experience, their odds of having an anxiety disorder was more than 4 times higher. For women whose income equaled or exceeded their male counterparts, their odds of anxiety disorder were greatly decreased. Similarly, the odds of an American woman being diagnosed with depression in the past year was nearly twice that of men. However, among women whose income was lower than their male counterparts, the odds of major depression were nearly 2.5 times higher than men. Among women whose pay equaled or exceeded their male counterparts, their odds of depression were no different than men. 5. They consider pay inequality, and the underlying discrimination and biases that may be associated with it, as the reason why women experience more anxiety and depression than men. Specifically, that some of the gender disparities in depression and anxiety may be due to the effects of structural gender inequality in the workforce, and the norms, expectations, opportunities surrounding the types of jobs women occupy and the way those jobs are valued and compensated relative to men. Jonathan Platt, PhD student and lead author, stated that the social processes that sort women into certain jobs, compensate them less than equivalent male counterparts and create gender disparities in domestic labor have material and psychosocial consequences. He also said if women internalize these negative experiences as reflective of inferior merit rather than the result of discrimination, they may be at an increased risk for depression and anxiety disorders. According to Catherine Keyes, senior author of the study, while it is commonly believed that gender differences in depression and anxiety are biologically rooted, these results suggest that such differences are much more socially constructed than previously thought, indicating that gender disparities in psychiatric disorders are malleable and arise from unfair treatment. They refer to a need to review policies which must go beyond prohibiting overt gender discrimination, relating their findings to a clear political agenda. 6. It would not be possible to infer a causal relationship from the information provided. The authors place emphasis on gender discrimination as a prominent explanation for mental health disparities between men and women. Although the findings highlight an association between gender disparity in pay and mental health outcome based on this sample population, A causal relationship or the direction of interaction has not been established, so the claim that gender disparities in psychiatric disorders are malleable and arise from unfair treatment cannot be substantiated. Similarly, this particular study did not investigate whether women internalize these negative experiences as reflective of inferior merit rather than the result of discrimination, so the impact that this might have on increased risk for depression would warrant further research but is speculative in the context of this study. The press release does refer to past research that has looked at factors like differences in sex hormones and coping mechanism, but has so far not provided an adequate explanation. The same could arguably be said of the issue of disparity in pay. While a partial, contributory factor, this too has not provided an adequate explanation when subjected to a critical reflection. Apart from those already mentioned, sex hormones, coping mechanisms, pay gap, what other factors could be contributing to the gender disparity? Income is a strong predictor of health outcomes, including mental health. The lower the income, the greater the risk, but questions remain around psychological factors, differences between full-time and part-time employment, employment choices, working hours, occupational and employer differences, including social environment, management structure, working arrangements, diet and lifestyle, pre-existing health conditions and so on. It would therefore be worth following up by reading the published paper and seeing to what extent these issues have been considered and what other confounding factors, other than education and experience, have been taken into account. Back to Activity 8, Examining Issues Further, Part 2. Activity 9, Treatments for Anxiety. Discussion. 1. Claire mentions taking sertraline, a selective serotonin reuptake inhibitor, or SSRI, which also works as an antidepressant. She says that she has also received a course of cognitive behavioral therapy which helped to retrain her brain by neutralizing the negative thoughts that she had and replace these with more rational ones. She exercises a lot, going to the gym 3 times a week. And she says the biggest treatment for her has been exposure therapy, where she puts herself in situations that make her uncomfortable. 2. She has accepted that being nervous is a completely natural emotion and not a symptom of a bigger problem and has a positive outlook, accepting that feeling, but doing it anyway because it might be fun, and it's never as bad as you think it's going to be. 3. Scott mentions that he recognizes that his anxiety may never be cured but that it is an acceptable part of who he is and his personality. He talks about SSRI antidepressants and benzodiazepines, a class of tranquilizers that he says help with severe anxiety. He also refers to mindfulness meditation, which he says can be highly effective, and relaxation techniques such as breathing exercises, and the importance of sleep and regular exercise. He also stresses the importance of maintaining an optimistic outlook to mitigate anxiety. 4. Scott refers to the amygdala as the seat of fear, and Claire says that exposure therapy can retrain her amygdala not to go off every time she is in the situation in the future when there is no danger. Recall the function of the amygdala, a key brain structure within the temporal lobes involved in the neural circuitry of anxiety, which was discussed in Section 4. Parts of the amygdala are involved in triggering the responses we associate with fear, e.g. submission, fleeing, or freezing on the spot. Other regions within the amygdala elicit feelings of bliss or peacefulness, or evoke aggression and attack. 5. He describes resilience as a trait that makes you resistant to developing anxiety and depression, that is somewhat encoded into your genes, but also something that can be learned. 6. He gives the example where your heart's racing very, very fast, and you think you're going to have a heart attack or you're going to pass out. It makes sense to sit down, try and take weight off your feet. Do some breathing exercises to calm your breathing down, because you have this belief that otherwise you're going to die. 7. Nick Gray explains you never learn that if you didn't do these kinds of precautions that actually you'd still be okay, and that whilst a panic attack is very frightening and feels awful, it's not in fact dangerous. He identifies cognitive behavior therapy, which helps people learn that some of the things they do to help themselves are probably unnecessary, as one of the most effective treatments for anxiety and panic attacks. 8. Claudia notes that exposure therapy allows the individual to gradually get used to things that she fears, referring to Claire's social anxiety. Nick explains that trying to hide your anxiety or trying to manage your image actually makes you more self-focused, more self-conscious, and one of the things that they would do as part of treatment for people with social anxiety is to video record them, so they can compare how they feel while in the moment with how they actually come across in the recording. He notes that almost always people are surprised by how they look and how they sound on video compared to how it felt to them. And that people tend to have a visual image of themselves, of how they're coming across looking red in the face, looking anxious or having a panic attack. 9. Nick explains that the aim is not to rid people of anxiety, which may not be a realistic goal, but rather to have a discussion around the normality of fear and worry and anxiety. Back to Activity 9. Treatments for anxiety. TED Talk, Alison Sommer. Anxiety disorders and panic attacks. Transcript. Alison Sommer. I have an anxiety disorder called obsessive-compulsive disorder or OCD. I have a form of obsessive-compulsive disorder that causes me to become anxious or frightened when something wrong or unexpected happens, like if somebody sits at my seat at the table. It also causes intrusive thoughts. These are thoughts that come unbidden to my head about things that I've done in the past or things that I might do, things that could happen by chance or because everybody secretly hates me. As you might imagine, these intrusive thoughts are really quite anxiety-producing. And this anxiety can manifest in different physical and emotional responses, one of which is the panic attack, which I'll be talking about more in depth later. But the thing that made me really hyper-aware of the effects of my OCD, and made me determined to spread awareness about anxiety disorders in general, is that my own symptoms were not always this severe. So I want to start at the beginning. As long as I can remember, I've always been sort of an obsessive-minded child. I would take a thing, good or bad, and roll it over in my head over and over. I was also really shy and awkward. And I know, especially at Carleton, a lot of you are thinking, yeah, me too. Laughter, because there are a lot of shy, awkward people and all of us have our little obsessions. I don't know if there's a scale for being shy, awkward, and obsessive, but I always felt like I was toward the high end of the range. Weirdo and freak were terms I readily accepted as a teenager. And when all the other girls my age were really into the Backstreet Boys I'm dating myself, I was obsessed with Star Wars. Sort of still am. I got in trouble for coming home late for curfew once as a teenager, and as punishment, my parents took away my Star Wars stuff and I thought that the world had collapsed. I also had on-again / off-again issues with anxiety and depression. And anxiety and depression really go hand in hand, like two best friends who like to corner a third person and make them feel like shit. Laughter. So there I was, this anxious, awkward, obsessive, and sometimes depressed girl. And that was life. That was my normal. When I got a little older and started coming out of my shell, and meeting people with similar interests to me, like the folks here at the Sci-Fi House at Carlton Benton House, anyone. Woo. Laughter. I started actually opening up, and talking to people about my feelings. And I started to realize that there were other people that were like me, that suffered from anxiety and depression. And suddenly, I went from feeling, instead of feeling like a freak, I felt like just kind of a normal anxiety depression story with a little obsessive behavior thrown in for good measure. And that actually felt pretty cool. So that was my life. I also started to get a little help then. I saw my first psychiatrist, got my first meds, and things were going pretty good. And then I got a really bad concussion while I was playing hockey. Love the sport. Still play it. But it was bad. That's when things took a nosedive from me feeling like normal, Hayatrons in the family crazy, to scary crazy. That's when the intrusive thoughts started getting louder and louder. This clicker sucks. Laughter. And it was bad. It was really, really bad. I was angry all the time. It mostly came out at my husband. But my road rage was also pretty epic. And while I was being an ass to other people, I was also being an ass to myself. I was not eating. I was down to a size 0, and the thought monkey was saying, "You can get skinnier." And I didn't want to accept that I had a problem. I wanted to feel like I was kicking ass. But I knew deep down that there was something wrong, because I wasn't sleeping and my marriage was going through the shitter. But trying to even think about changing my habits, really thinking about changing any of my habits, would give me massive anxiety. And this anxiety was leading to panic attacks. Panic attacks are one of the most frightening manifestations of anxiety. I know if you've never had a panic attack, the name sounds kind of lame. We all have those moments of panic, like, oh, did I leave the oven running, or my kid just bolted out in the middle of the street, or maybe more for you, I forgot to study for that test. But none of these are panic attacks. The Mayo Clinic's website says that a panic attack is a sudden episode of intense fear that triggers severe physical reactions when there's no real danger or apparent cause. Panic attacks can be very frightening. When a panic attack occurs, you might think you're losing control, having a heart attack, or even dying. That's a pretty good definition. But what does it really feel like? That's what I'm going to try to show you. Okay. So it's a pretty normal day, but maybe a little bit stressful, like in a performance evaluation at work, or packing for a vacation. I'm doing something pretty normal. And I start to feel off. I know something's not quite right. I'm getting tingly. That tingling numbness creeps up my neck and all over my face and seeps into my head. I feel dizzy, so I sit down. Sometimes I think maybe I just didn't eat enough today, so I grab for some crackers or a candy bar or whatever I have. My head is feeling fuzzy. And as I'm sitting there, sometimes I think, oh, my gosh, it's seizures or a heart attack. But I know better. I know it's a mounting panic attack when my heart starts beating harder, not faster, really, just hard, like the heartbeat in the background of a horror film. Now I'm getting scared. I'm thinking, no. No, not here. Not now. Right now, the right medication might help, might bring this crescendo back down and end the panic attack. But sometimes even the right medication doesn't always help. I feel off. And I want to sit still, but my body just won't listen. So I pace. I lash out. The tears come now, broken, dry cries. Weak, angry shrieks break through. And my brain is screaming, shut up, shut up, shut up. Not a real cry. Nothing that could be cathartic can come out. It all gets caught in my throat and in my head. Oh, I get angry, mad at this feeling, myself, and everything. I pound my head with my fists. I want to bang it against the floor. I want to smash my skull and make it all end. And sometimes I do. I just hit myself. And I can't hold back. And it feels like relief, suddenly, that physical pain. And I crave physical pain, cuts, burns, bruises. And then that scares me even more. And I look up on my shelf of pill bottles and I think, I could take them all. I could end it right now. But I don't. Crying I don't. Real tears come now. So sad tears. But now I can lay down, and just wait for it to be over. Eventually, it ends. And it always does end. And I'm still here. And with my sanity coming back, and with my head clearing, I'm grateful to still be here and that it always stops eventually. This is not an easy thing to live with, knowing that it could happen at any moment, any place, at home, at work, at the tattoo parlor. That's happened. And not a lot of people talk about it, even though a lot of people go through it. When I first posted to my blog about my experiences with panic attacks, I was surprised when people started contacting me from all corners of my life and the internet to tell me about their experiences, and to thank me for speaking out, and told me I was brave. It got me thinking. You know, these days, everything seems to have an awareness month or a ribbon or some picture you can share on Facebook to spread awareness. Well, I've made this sort of my panic attack awareness effort. And now I hope all you know a little bit more about what they really feel like. As for me, my husband did finally get me to see a doctor. It turns out that my anxiety and obsessive tendencies had basically been given steroids by the concussion, and I was diagnosed with severe OCD. And we started the dance of trying to find the right combination of meds and therapy. We're still figuring it out. I still have panic attacks. But luckily, thanks to some wonderful people and some magical chemicals, they're fewer and further in between. And blogging about it and talking about it is part of my therapy, too. I'm very blessed to have such a wonderful support structure here in my life and to have been given these opportunities to talk openly about my anxiety disorder. 40 million adult Americans, according to the National Institute for Mental Health, have anxiety disorders. That's just over 18% of the population. So chances are you know someone with an anxiety disorder, whether it's a friend, a colleague, or even yourself. Of the 40 million who have anxiety, 15% of them experience the terror of panic attacks. And it's twice as common in women as in men, because we're lucky. Laughter. When I'm having a panic attack, the best thing that people can do for me is to just be with me and let me know they're there for me and will do things I ask that I say I need, whether that's to open a window or let me run away from the room or turn out the lights, none of which you can do on an airplane, by the way, turns out. Laughter. And so if you're there when someone you know is having a panic attack, it's hard to breathe in the middle of attack, much less speak. So instead of asking them over and over, "Are you okay? What's wrong? Are you okay? What are you panicking about? What can I do? Are you okay? Are you okay?" Just be there, let them know you support them, and sit with them as they ride out those waves of panic. Because you can't tell a panicking person to calm down. That's like trying to tell someone with a gaping wound to just stop bleeding. Laughter. But what you can do is let them know you're there for them. It may make you feel helpless, but your presence is more comforting than you may realize. And then when it's over, then you can ask what you can do for next time, if anything, really. But one thing we can all do is work together to end the stigma surrounding mental health disorders like anxiety so that everybody who needs help can feel safe in asking for it. You can help by showing respect to people who seek the aid of therapists, psychiatrists, and medications. Instead of telling someone to work harder or worry less, tell them that you're there for them, and you understand these things can be a struggle. If you have anxiety, it's not your fault. Help is available in many forms. I started getting help by working with my primary care physician, but there are also hotlines and websites such as the Anxiety and Depression Association of America at ADA.org. In short, if you or someone you know has an anxiety disorder, give help, get help, speak out. You're not alone. Applause. Back to TED Talk, Alison Sommer. Anxiety disorders and panic attacks. Uncaptioned interactive content. Transcript. Claudia Hammond. I'm Claudia Hammond, and today we're focusing on a single condition, a condition that can take over a person's life, preventing them from going out, from working, even from sleeping. The condition I'm talking about is anxiety, thought to affect around 1 in 14 people around the world in any given moment. The effects can be profound. Female voice. Claire. Rather than thinking, "Oh, I'm nervous," you think, "I don't want to have a panic attack." And for me, I usually start thinking, "I can't do this. What if somebody notices? What if I make a fool of myself? What if I end up in hospital? What if I end up on the streets?" It escalates into something catastrophic, which isn't the reality, but those are the thoughts that go through my head rather than, "Oh, I might have a nice time," or, "This might be tricky but it will be okay." I'm thinking I'm going to die. Claudia Hammond. Today we'll be looking at the causes of anxiety and the cures, and asking whether it's on the increase. My guest today is clinical psychologist, Nick Gray, from the Centre for Anxiety Disorders and Trauma at the Maudsley Hospital in London. So, Nick, you see a lot of clients experiencing anxiety. Is it possible to define what it is? Nick Gray: I guess a reasonable definition would be that this is a kind of feeling of worry, fear, nervousness that people would have about something that's got an uncertain outcome. That's a very sort of lay definition, I think. Claudia Hammond: Now, some people experiencing anxiety, like Scott Stossel, the editor of the American magazine The Atlantic, managed to keep it secret from their friends and colleagues, but in the end his anxiety became so serious that he nearly missed his own wedding. As an author, he found publicity tours for his books so stressful that he decided to make anxiety the topic of his next, The Age of Anxiety, which of course has unfortunately resulted in another book tour. I asked him what anxiety feels like for him. Scott Stossel: It can be more generalized, that feeling of worry, feeling of churning in the back of my mind, worrying about every conceivable negative outcome, and sort of pessimistically anticipating the worst. That in some ways is the milder form of anxiety. The most acute form comes in two different genres. I would say one is just the sort of acute onset panic attack. You would lose the ability to just think straight. And you start sweating, and you're hyperventilating, and you feel like you can't get enough breath. And you feel as though your chest is constricting, and you feel various forms of gastric distress. It can be quite terrifying and uncomfortable. You can have the similar sort of reaction in response to a phobic stimulus. So I have a number of specific phobias and, for instance, flying, heights. And if I'm, in an airplane, you can experience symptoms that are basically akin to a panic attack. But in those cases it's triggered directly by the thing that you fear. Claudia Hammond: Now Nick, he mentions there the thing that you fear, and for him there seem to be quite a range of triggers. Is that unusual for people to have so many different phobias at one time? Nick Gray: No, I mean, what we find with people with anxiety problems is that there might be a kind of a range of fears that they have, but there's usually kind of one or two which are kind of most prominent and kind of like the worst fears that they would have. Claudia Hammond: So is that different from, say, somebody having a phobia just of spiders? Would that count as anxiety still? Nick Gray: It definitely counts as anxiety. Anxiety is a normal process. It's something that I think we all have at one time or another, and it's important for us to, kind of help keep us safe and help keep, our loved ones safe as well. If we see our kids running into the road and there's a car coming, we'd feel anxious, and that's a good job that we do. I think what is less commonly the case is that people have this sort of disabling and chronic anxiety problem. I think that's what Scott's talking about. The good news is that there are effective treatments for these now. Claudia Hammond: We will talk about those later. And anxiety is something we seem to hear a lot about these days. We like to talk about the stresses and strains of modern life and how much harder it all is now. But as part of his research, Scott Stossel has looked back in history and he's concluded that anxiety is nothing new. Scott Stossel: Reading back through the historical literature, going back literally thousands of years, is that it seems like every age, whether that's each successive generation of the 20th century, or going back to the Renaissance, or going back to the late Roman Empire, or even the 4th century BC in Greece, every age presumes to think that it is the most anxious age ever. You'll find physicians in the 2nd century AD Rome saying, "Never have there been so many anxious, miserable, melancholic people." And you look through British history, the Victorian era, the Georgian era. And so you start to realize that clearly some quotient of anxiety is relatively fixed throughout the human population and endures and is part of the human condition. So some percentage of people are going to be anxious all the time. But I do think, all that said, that certain eras are more productive of anxiety than others, and those tend to be eras like the Industrial Revolution or the Gilded Age, or now, where you have rapid technological change, where the economy is uncertain, where you have rapid social transformation and changing ideas of gender identity. And the feeling of uncertainty produces anxiety that can actually rewire your brain to be more anxious. Claudia Hammond. So Nick, do we have any idea how many people do have anxiety disorders today, and would it be fair to say that they're on the rise or not? Nick Gray. I think the evidence is that actually they're not on the rise. Maybe we're talking about them more and there's perhaps a little less stigma in talking about them. I think the best evidence is the quote that you gave earlier on, which is about 1 in 14 people worldwide would meet the criteria for an anxiety disorder. Claudia Hammond. And is it fair to argue that it's something of a Western concept, and do anxiety disorders and the levels of those go up in countries as they become more westernized? Is it a Western construct in a way? Nick Gray. Well, that's a really interesting question, and unfortunately there's not been, really enough research outside of, America, Western Europe, and Australasia. The evidence that there is actually, those, like Western Europe. Anglophone countries have about a 20 to 50% more greater likelihood of meeting the criteria for this kind of chronic anxiety than people from, other cultures, African cultures, Indian, Asian cultures. But that might be to do with the way in which we're measuring anxiety, the questions that we're asking. What I don't know, and what I don't think the evidence is currently showing, is that as countries become perhaps more westernized in that way, or perhaps more affluent more generally, whether that leads to any increase in anxiety. Claudia Hammond. And then I suppose you don't know whether it would just be that more people are getting diagnosed. Maybe that anxiety is there but doesn't get diagnosed because people don't have the opportunity to have it diagnosed, or maybe it isn't there. Nick Gray. Perhaps. But certainly in the studies that have got the best kind of evidence, at the moment they're not looking at people who have almost, the opportunity to be diagnosed. They are looking at, community studies. So they're, having researchers, ask people whether they're seeking treatment or not. So this isn't anything to do with the treatment-seeking rates per SE. Claudia Hammond. So what's interesting is, what causes one person to experience extreme anxiety while another doesn't? Scott has noticed a phobia of vomiting running in his family. Scott Stossel. My mother had that phobia fairly severely, and I'd always thought that I'd acquired my phobia, they call it emetophobia, from seeing her worries. So I took particular care, at least tried to conceal my phobia from my daughter. And then a few years ago, when she was 7 years old, which as it happens was the exact same age when I developed my phobia, give or take a few months, she started expressing it in very similar ways. Which was both heartbreaking and fascinating to me, because it wouldn't seem that something as idiosyncratic as emetophobia could be transmitted through the genes. So I mean, my own conclusion based on, the work of experts who study this regularly said there is a very strong inheritable component to one's predisposition to have an anxious temperament. But all that said, anxiety is not wholly reducible to genetics, I think that lays the basis for your propensity to be anxious. But then on top of that there is your upbringing, your life circumstances, your life, whether you were subjected to trauma, and a certain component of luck. Claudia Hammond. So it's that age-old question that we always face in psychology of how much is it down to the environment and how much is it down to genetic factors? Is there evidence that anxiety can be heritable, or is it just that we copy what we see in other people? So, Scott sees his mother and sees that she doesn't like vomiting. Nick Gray. I think Scott summarized it really nicely. There is a genetic propensity to have, say, an anxious temperament. And then it's the life experiences and traumatic events and the things that you observe but then determine how that plays out or not. Claudia Hammond. And there do seem to be certain things that we're more likely to have phobias of, aren't there, like snakes and spiders? Not everyone's afraid of them, but more people are, and monkeys, for example, are afraid of, say, snakes as well. Nick Gray. Yeah. This sort of hypothesis from basic psychology around preparedness that there are some things that we're, perhaps in an evolution return. We're more prepared to develop phobias to such things which can immediately, cause us harm, dangerous animals. Things like vomit phobia, about, disgust, making sure the germs aren't inside us. But then other phobias can develop really, following traumatic events. So we can develop an anxiety response to almost any stimulus if it's associated with a, traumatic experience that we've had. Claudia Hammond. And you mentioned evolution there. And Scott points out that we have all evolved to feel a degree of anxiety. Scott Stossel. Darwin talked how species that fear rightly enhance their chances of survival. And if nobody felt fear, if you didn't have the fight or flight response, we as a species, if that hadn't been bequeathed to us by evolution, we probably would have gone extinct long ago. So some quotient of anxiety is highly adaptive. But I think for many people, and particularly people with anxiety disorders, there can be a gap between the public presentation of competence and confidence in the internal sense of, imposter syndrome, feeling like you're inadequate. So everybody struggles with a little bit of anxiety, but people have acute anxiety disorders and many people are quite good at hiding it. And that leads to, what one therapist I talked to calls impression management, where you're always in mortal terror of the vulnerable, anxious self within being revealed, which in itself becomes kind of a contributory anxiety because you're trying so hard to keep that inner, vulnerable, anxious imposture self from being revealed that you have to put all this work into maintaining your external impression or your brand. And that's the symptom and a cause of additional anxiety. Claudia Hammond. Nick, I wonder whether there's something you recognize in your clients? Do you see this sort of desperation to maintain a public face and to not have people know about it and to keep that anxiety a secret? Nick Gray. I think it's very true of many of the people that we see, and I think it's particularly true of those people who have, problems with, social anxiety. A social anxiety disorder where their worst fears are about showing signs of anxiety or saying or doing something that would be embarrassing or humiliating. And then other people thinking badly of them. Claudia Hammond. Well, our reporter Lynn Ginsberg has been to meet Claire, who has social anxiety disorder which she thinks was brought on by her job. Lynn Ginsberg. So I'm in the park with Claire, who's agreed to meet me just outside of work, and this is a situation that maybe a couple of years ago would not have been so pleasant. So can you tell us why that might be? Claire. Well, 18 months ago I was dealing with a very bad period of anxiety, severe anxiety, and panic attacks. And I'm right outside my office, which is where most of it takes place. So, yeah, a couple of years ago this wouldn't have been a particularly nice place for me to be. I'd want to be as far away as possible. Lynn Ginsberg. And what kind of events in your office would make you feel anxious? Claire. Well, I work in an office with very strong characters, which doesn't necessarily mean they're bad people, it just means they're a lot louder than me, more expressive than I am. And I put a lot of pressure on myself to, compete and confirm. It actually relates back to school in many ways for me, because I felt the same way in classrooms. I need to be like these people, I can't be like myself, I need to be like this. And the pressure to be like that eventually made me ill, unfortunately. Lynn Ginsberg. And when did you realize that that was the case, that you were reacting to these situations that are distressful for everyone in a different way, and in a way that needed to be managed? Claire. It was starting to keep me up at night, I noticed. It was little things at first, meetings, or presentations where I had to say something, and eventually it spiraled into I wasn't sleeping at all because I was so worried about it. And I was worried about speaking to certain people at the office. And certain things, like I developed quite a bad tremor and heart palpitations. I had difficulty breathing. All the sort of common side effects of anxiety, really. Claudia Hammond. Now Nick, I thought it was interesting there that Claire compares her competitive work environment today with being at school and says it feels a bit like that. When you're talking to clients about their anxiety, how much would you talk to them about their past as well? Nick Gray. Certainly that's, kind of, where the evidence is in treating anxiety disorders. It's trying to work on what's keeping the problem going now. As part then of, as we go on in treatment, think about how we can try and prevent the anxiety, kind of, recurring. And I think that's probably when we talk much more about perhaps the kind of the origins of it and how it may be that people are reacting to situations in the adult world now which are actually just an echo or ghost of, kind of, like the earlier experiences such as at school. Claudia Hammond. Do you ever find that clients sometimes can see this upside even though it can be so disabling for them? Nick Gray. I'm going to say I think in the kind of the health clinics in which I'm working there are very few upsides to experiencing, kind of, chronic anxiety, although I consider, maybe, see upsides to the, kind of, the normal process of, kind of, worry or fear. I think the one area perhaps where people can have some kind of form, of almost like personal growth from overcoming adversity or seeing that they can have perhaps, kind of, greater levels of empathy and compassion for others who are also, kind of, experiencing difficulties. But certainly most of the people that we're seeing would say that their kind of chronic anxiety disorder is really a negative thing, and they want to be, kind of, be rid of it as far as is possible. Claudia Hammond. Yes, because I guess actually experiencing a chronic anxiety disorder is different from just a touch of perfectionism, say. Nick Gray. I think so, yeah. Back to, Uncaptioned interactive content. Uncaptioned interactive content. Transcript. Claudia Hammond. Claire, who we heard from earlier, has tried a range of different treatments. Claire. I now take a mild antidepressant called sertraline, which is an SSRI inhibitor. Lynn Ginsberg. So a selective serotonin reuptake inhibitor. Is that right? Claire. That's the one. And so I take that, and I also did a course of cognitive behavioral therapy which helped me to retrain my brain by neutralizing the negative thoughts that I have with more rational ones. I exercise a lot. I go to the gym 3 times a week to keep my adrenaline levels down in a healthy way. And the biggest one for me actually is what I call exposure therapy, whereby I put myself in situations that make me uncomfortable in order to retrain my amygdala in my brain not to go off every time I'm in the situation in the future because there is no danger. I'm always going to be a little bit nervous, but for me it was exacting that being nervous is a completely natural emotion. It's not a symptom of a bigger problem. People get nervous before interviews and people get nervous before they meet new people. That's 100% fine, and it's just about accepting that feeling, but doing it anyway because it might be fun. And it's never as bad as you think it's going to be. Claudia Hammond. Scott too has come to terms with the fact that he's never going to be entirely free from anxiety, but that he can manage it. Scott Stossel. I may never be cured, but I can come to terms with the anxiety and recognize that it is an acceptable part of who I am, and it comes with certain elements of my personality that may be favorable. There are many things that I have, therapies and techniques that I've used, that do help. Certain medications help a lot in certain circumstances, and obviously, you know, medication works in different ways for different people. But SSRI antidepressants and benzodiazepines, which are the class of, sort of, minor tranquilizer, help a lot with severe anxiety. Mindfulness mediation, I've not probably explored that enough myself, but there is lots of evidence that that can be highly effective in literally reshaping your brain, of strengthening the rational part of your brain and literally shrinking the amygdala, which is the seat of fear. So there's a lot of evidence that that works. And then many psychiatrists will say there are, you know, if you're in the throes of a panic attack or if you're feeling overwhelmed, do breathing exercises to help yourself calm down. And then any doctor or dietitian or psychiatrist will tell you sleep is incredibly important, Regular exercise is incredibly important, and cultivating what the psychiatrists today talk about resilience, which is a trait that, makes you resistant to developing anxiety and depression. Resilience too is thought to be somewhat encoded into your genes, but it's also something that can be learned. The military is studying how can they make soldiers at the US military, make their soldiers more resilient so that they're resistant to breaking down with PTSD after combat. So cultivating a resilient, optimistic outlook is probably one of the more effective things you can do to mitigate anxiety. Claudia Hammond. Now Nick, trying to accept your anxiety as part of you, sounds like very good advice, but is it easier said than done when it feels so unpleasant? Nick Gray. Yeah, I think it is easier said than done. I think there are also things that people do with the best of intentions that actually serve to keep the anxiety going. And I think that one of the things that, the effective treatments do is to try and identify what those, maintaining sort of factors are. And then to try and help change those. Claudia Hammond. What sort of things might someone do that maintain it? Nick Gray. Well, the, things really similar to, like Scott and Claire have mentioned, is that people do things to try and prevent the worst from happening. So if your heart's racing very, very fast, and you think you're going to have a heart attack or you're going to pass out, it makes sense to sit down or to try and take your weight of your feet. Do some breathing exercises to calm your breathing down. Because you have this belief that otherwise you're going to die. The problem is, of course, is that whilst a panic attack is very frightening and feels awful, it's not in fact dangerous, yet. And one of the things doing these precautions, these things to save yourself, is you never learn that if you didn't do these precautions that actually you'd still be okay. So one of the things that, the most effective treatments in anxiety is typically cognitive behavior therapy, is to help people learn that some of these things they do to save themselves are probably unnecessary. Claudia Hammond. So is that where Claire was talking about exposure therapy and gradually getting used to the things that she fears? Nick Gray. Yeah, partly, and actually certainly for people with social anxiety disorder it's moved really, beyond pure exposure therapy now. And it's really looking at not just, exposing yourself and grinning and holding on to, the nearest chair until the anxiety passes, but it's really looking at what your predictions are. What do you think is going to happen? And how can you, really test that out? And also in, social anxiety, one of the things that happens is that people often try to hide their anxiety, something I think Scott mentioned. And one of the things that trying to hide your anxiety or trying to manage your image does is it actually makes you more self-focused, more self-conscious. And if you're more self-conscious and self-focused, you're not really paying attention to what's going on out there. You're not paying attention to how people are really reacting to you, so it may feel as though some of your fears are coming true, but the reality may be that may not be the case. One of the things that we would do as part of treatment actually for people with social anxiety disorder is actually to video record them as part of treatment. Claudia Hammond. That sounds horrible. Nick Gray. It's certainly anxiety provoking, but of course one of the things about it being anxiety provoking is that then their fears are activated. Their fears of whether they're looking shaky or whether they feel that they're going red, or fear that they're saying something stupid and how it feels to them at that moment. They can then compare with how it actually looks on the video. And one of the things that certainly we find in treatment is that, almost always people are surprised by how they look and how they sound on video compared to how it felt to them. Claudia Hammond. So even though they might be cringing at the beginning, it's still not actually as bad as what they were imagining? Nick Gray. Absolutely. And one of the things we guide people to do is to look at it as if they were watching TV, as if they were watching somebody else rather than busy criticizing themselves when they're watching it. But just to, see it as if somebody else would. And then, usually it's the case of what they're seeing, what they're hearing is very different to how it felt at the time. Claudia Hammond. And sometimes you were using imagery in your work as well. What's that and how would that work? Nick Gray. Yeah. And this is certainly something that's, kind of, been a development over the last kind of 10 or 15 years in anxiety disorders, that some of the worst fears that people have aren't just kind of like a verbal thought like I'm going to die or people can see I'm looking red. But they have an image of either how they're coming across. They have an image of themselves looking red in the face. They have an image of themselves kind of looking anxious, or they may have an image of themselves actually kind of collapsed in the street from a panic attack. Certainly a person that I treated with panic disorder some time ago, he actually had an image of a blood clot moving around his body. And the fear of this then, kind of, reaching his heart, when his heart was racing, he feared that this blood clot that he had in this image was going to stop his heart. Claudia Hammond. So after people have had some sort of treatments like possibly medication as Claire and Scott were talking about, or cognitive behavioral therapy like this, what sort of outcomes do you see? How easy is it to actually rid people of their anxiety? Nick Gray. I don't think we rid people of anxiety. I don't think we ever aim to rid people of anxiety, and if people come in with a goal of saying I never want to be anxious again, yeah, we need to have kind of a discussion around actually the normality of fear and worry and anxiety. And what's kind of realistic in those terms. Back to, Uncaptioned interactive content.